we would transit to a very important session. The session is dedicated to the platinum sponsor of SHANCON 25, Medel, who has graciously supported our conference. I now would like to introduce the chairpersons of the session. Firstly, I would like to introduce Professor Dr. Pavina Raimaji. Professor Raimaji, Head of the Department, ENT HNS, TUTS Maharajan Medical Campus. She is the recipient of Fellowship in Implantology, Chennai 2018, which has been serving as a prominent faculty in her department for around 2 decades, with over 70 national and international publications. Her expertise lies in otology and CI surgery. Similarly, I would like to introduce Mr. Pradeep Kumar Malik. Mr. Pradeep Kumar Malik is a senior audiologist and speech language pathologist, currently serving in the speech and hearing unit at National Academy of Medical Sciences, Veer Hospital, Kathmandu, over decades. He also holds a fellowship in pediatric audiology and speech FPAS from Thailand. I now request our respected chairpersons to further introduce the speakers of Medal Symposium and talk about Medal Symposium. I hand over the session to the respected chairpersons of the session. Thank you.
And welcome to our Medal Symposium, a long-awaited session. And on behalf of myself and Mr. Pradeep Malik, I welcome you all. And going by the theme, empowering individuals with communication disorders, a multidisciplinary approach, Medal, do they need introduction? I don't think so. But still, I've been given the job of chairing this session. So let me introduce the platinum sponsor, Medal. We would like to acknowledge our platinum sponsor, Medal, who is a global leader in hearing implant technology. Medal has been pioneering advancements at the forefront of innovation since establishment around 1990. Headquartered in Innsbruck, Austria, the company has been developing cochlear implants and other hearing solutions that have transformed lives by connecting people to the world of sound. So, does it go to the theme? Yes, definitely. Medal has been empowering individuals with communication disorders, a multidisciplinary approach, of course. So, let me start the session now. I welcome Dr. Christian Emil Steffen, Regional Manager, Medal, on the dais to give his speech. Thank you and welcome. Dr. Christian Steffen.
Gladly this days everybody sing. So I'm very happy to introduce you to our company, but not only to our company, but also to the activities of Medal in Nepal, and especially I would like to focus on our activities in the field of hearing and speech, and especially in the field of audiology. Maybe we can go to the next slides. Oh, that works perfectly well. Thank you very much. So our company has a mission in hearing, and our mission is we want to overcome hearing loss as a barrier to communication of quality of life, and we effectively and at the same time gently restore hearing by offering a comprehensive set of hearing implant solutions. And we thus provide the best benefits to individuals with a hearing loss today, tomorrow, and worldwide. As you can see, our activities are meanwhile almost all over the world. So we are doing implantations in more than 130 countries all over the world, more than 5,000 clinics. We have a staff of 3,000 people worldwide and 1,800 people in our headquarters in Innsbruck. I had the honor and the pleasure, unfortunately he's not here in the hall at the moment to speak to Dr. Rakesh today, and we were a little bit reflecting on the history of cochlear implantation in Nepal. And Nepal has, in fact, quite a long-term history in cochlear implantation. And we shared this experience from the very beginning in, I think, 2004, he mentioned. But as our activity is not only in cochlear implantation, in hearing implantation, also in the field of audiology, are getting more and more and more active, I'm very, very happy to announce today that I have the big honor and privilege from now on, from this month on, to manage directly from headquarters in Innsbruck, Nepal, together in close cooperation with our local representative, those who are representing MEDAL here in Nepal. It is our long-term colleague and long-term representative, Mr. J. Krishna Shrestha, the CEO of General Medical Suppliers. Warm welcome to you, Jay. And with Ms. Grishma Basnet, she's our Sales and Marketing Head for MEDAL Hearing Solutions in Nepal. Warm welcome also to you. So I hope with that we are going to a new stage of our history in Nepal as well. But let me also inform you, before I really focus on the part that is really important and interesting for you, about where our products come from. So all our products are manufactured and developed in Austria, Innsbruck. So you see here a small impression about our, sorry, I have to switch to the next slide, to our R&D building in Innsbruck and our manufacturing building. So all the implants that are coming from there are manufactured with the highest standards, highest European standards in Austria. When we are talking about our implants, it is very, very important for us to highlight that our implants have the highest status of security and innovation. So we have 3 Tesla MRI conventional implants with magnet in place. We have an S-vector magnet. We have a central electrode lead. We have the widest electrode portfolio, and all our electrodes are designed for an automatic insertion. And I think this is very, very important that my colleagues who will speak after me will a little bit reflect more on this part, I guess. Sorry, switch back. So what is important for us? We offer a wide range of hearing implant solutions, not only CIs, but also middle ear implants, and of course bone conduction implants. What is very important is we would like to provide all our patients worldwide in every single country with state-of-the-art safety features, for example, 3 Tesla MRI conditional cochlear implants, individualization of hearing solutions with anatomy-based fitting and precise surgery is very important for us. Hearing preservation to preserve the residual hearing of our patients is important for us. And the main focus that I would like to highlight today is we would like to build up a strong support structure in every country where our hearing implants are used. And this is the part where I would like to focus on now, because I think this is the most interesting part for the audience here, which is mainly consisting of audiologists and speech therapists, and of course also of ENT surgeons. But I would like to focus on this topic. And what we have done over the last 4 years, we have started a program which was called the Hearing Health Care Alliance, empowering the hearing healthcare sectors in 14 emerging countries. And we did this program together with the Austrian Development Agency. And it goes very, very smoothly along with our mission. I've already mentioned that our mission is to want to overcome hearing loss as a barrier of communication and quality of life. And you know maybe better than I do that the World Hearing Report of the World Health Organization in 2021 has highlighted the goal that we should make ear and hearing care accessible for all people around the globe. And this is exactly the motto, the idea that is also standing behind our project with the Austrian Development Agency. Our overall goal is to significantly improve the diagnosis and the rehabilitation of people with hearing impairment by establishing sustainable local structures in hearing healthcare sector in 14 developing and emerging countries. What is the background behind this public-private partnership with the Austrian Development Agency? The Austrian Development Agency is an operational unit of the Austrian Ministry of Foreign Affairs, responsible for all the development-related issues, and it is a cooperation between us as a private company and the Austrian Development Agency. But what is reflected best is this graphic here. It should contribute to the welfare and the capacity building of the partner country, and it should also strive for a long-term structural benefit of the company in the respected partner country. And this is, so to say, the idea behind it. And we started our journey together with the Austrian Development Agency in 2 countries in 2018. This was Bangladesh and Cote d'Ivoire. And due to the big success of this cooperation, we could enlarge this cooperation to a strategic partnership in 14 countries starting in February 2022. We were very happy to welcome also a representative of the Austrian Development Agency, Ms. Susanna, who was present here in Nepal yesterday, and she was inaugurating the pre-conference. And in the middle you see our CEO, Ingeborg Hochmeier, and this is a historical picture because this was, so to say, the moment when our previous partnership was awarded with Austria's most prestigious award in corporate social responsibility, and this was the moment when we brought our cooperation with the Austrian Development Agency to the next level and started to go for a strategic partnership. We have a lot of stakeholders in this project. I don't want to go into detail about the international stakeholders, but what is very important and even more important to highlight is that we have more than 100 local partners, and this is what I would like to highlight now within the next 5 minutes in this presentation, what we could achieve within the last 4 years with our partners, with our local partners in Nepal in the field of audiology and speech language pathology and speech rehabilitation, because it's tremendous what we have achieved. So if you look at our project, all our projects follow this intervention matrix. So there's always an element dedicated to training and knowledge transfer. There's an element dedicated to capacity and development and infrastructure. There's an element which is focusing on early identification and hearing screenings. And last but not least, there's of course a lot of awareness and communication in order to bring the importance of this topic to different groups, decision makers, but also patients and parents, for example. If we look at this part of the world, we see that we have a huge amount of people that are affected by a certain kind of hearing loss. This is only, I made this calculation, I took just the average prevalence of hearing impairment of the 3 countries, and this comes already to almost 10%. So if we assume, and this is also conservatively assumed, a population of 200 million in all the 3 countries, we have more than 20 million people that are affected by a certain kind of hearing loss, and that's why, and if you compare this to the numbers of available specialists, for example in Nepal, we have only maximum 2 audiologists and speech language pathologists for 6 million people, then we see that there is still a very big need of qualified specialists in the field of audiology and speech language pathology. And this is exactly where our project was coming in. So what we did is in all the 14 countries, we were establishing newborn hearing screening pilot programs. Why did we do that? Because early identification and early intervention of hearing impairment is crucial, especially in countries of this region. It's also very important to collect national data, and by collecting this data to raise awareness for the importance of newborn hearing screening among decision makers, but not only among decision makers, also among parents and caretakers. So what we did is we provided state-of-the-art devices for newborn hearing screening and follow-up diagnosis. We were conducting trainings of newborn hearing screening and follow-up diagnosis. And we provided manpower for the infrastructure for the newborn hearing screening system. And the success was that we could establish systematic, universal, and quality-controlled newborn hearing screenings, pilot projects in almost every partner country of both regions, and we were publishing a lot of studies and data for the local stakeholders and governments. And let me just show you a few impressions what we have achieved in only 4 years in Nepal. So in 2022, we handed over the devices and we have made a workshop on device handling and newborn hearing screening. From 2022 to 2023 to 2024, we inaugurated new NHS facilities. We made ongoing screenings at the Tribhuvan University Teaching Hospital, and we made a newborn hearing screening refresher training at Dulichan Hospital, where we are also cooperating with. And in this period of time, we also had regular awareness-raising meetings with officials, and we were also publishing 2 newborn hearing screening studies based on 6,617 screenings that were performed in Tribhuvan Teaching Hospital. So this happened in only 4 years, and we established a pilot program that can be really taken as a role model for the whole country. A second part of all our programs in all countries was the support of university programs in audiology and speech language pathology. Why? Because it is obvious that we have a lack of qualified specialists in audiology and speech therapy. So what did we do? We developed together with our international faculties curricula that correspond with international standards. We supported these programs with international guest faculties, with online training contents according to the new curriculum, and with equipment with the state-of-the-art curriculums all over the world. So this is just a few expressions of what we did in the field of quality education in universities. But let me also touch upon a last element which was called professional certificate in hearing rehabilitation, which we also started in all our partner countries. Why did we do it? It's obvious. Also in this field we have a lack of qualified speech therapists, and we have a lack of local rehabilitation resources. So what we did, we started a 1-year blended learning training program that is also accredited by the HEBEL. We started a training of trainer program, building a local core teams. We made low threshold trainings for caretakers and parents, and we were starting a knowledge base also, which is always accessible on our Mental Academy. And without further delay, I would like to go also to some impressions from the last 4 years in Nepal. So in 2022, we started this professional certificate in hearing rehabilitation, and here in Nepal, in Kathmandu, when we were also inaugurating our program. Meanwhile, in these last 3 years, we were regularly having family curriculum workshops for parents, for caretakers, and also for teachers in Nepal. And last but not least, recently in 2025, we started the second batch of the professional certificate in hearing rehabilitation. And I think that all these activities shows that MED-EL is not only focusing on selling implants in a partner country. What is really, really important for us to build up a structure in every partner country that allows all the professionals to provide the best possible support to our patients. And I think this goes very much along with the idea of the World Health Organization to make ear and hearing care accessible for all. Thank you very much for listening to me for this short journey about our activities in the field of audiology, speech therapy. I'm very happy to be here, and I would like now to hand over to my colleagues who will say a little bit more about special topics that are really, I think, also important for especially audiologists and speech pathologists and speech therapists. Thank you for your attention.
MEDAL is involved not only in the electrodes, I mean the implants, but it's wonderful to see being involved in our academic programs as well, like ASLP program, the curriculum for the BSLP, and its various trainings. So ultimately, the goal is to make good individuals, and ultimately the patient will benefit. So it's really wonderful, and thank you, Dr. Krishan, for the wonderful presentation and making us believe that MEDAL is for education as well. Thanks a lot. And on a lighter note, thank you for the chocolate as well, all the way from Austria, and we'll be sharing. Thank you. So now, as a second speaker, I would like to welcome Ms. Shefali Casey, who is known to all of us and very dear colleague. She's a senior specialist and a special project. Welcome you, and over to you, Shefali.
Said MEDAL for education, and during my next talk, you will understand that MEDAL is not only for education but also for technology. So, when cochlear implants started, they were only able to provide awareness through sounds, okay, nothing else. Then the technologies developed, the electrodes developed, the processors developed, and then they were able to understand speech as well with cochlear implants. But was it enough? No. So what happens is, at that point of time, people were still not able to understand or enjoy music. They still had unnatural sound quality. That's when MEDAL worked on developing our technologies further. We introduced fine structure processing strategies. We made multiple electrodes available, which is suitable for every length of cochlea, and we made sure that it is possible to reach closest to natural hearing that is maximum possible with MEDAL cochlear implants. So how are we doing this? We have outer ear, middle ear, and inner ear, and all these parts of ear are responsible for certain functions. We are replicating this function as it is in MEDAL cochlear implants, and trust me, it is only MEDAL who is replicating as it is in the industry. So first, let's talk about outer ear. Outer ear not only transfers the sound, it also does something else. It provides emphasis to different frequency, right? So for low frequency sound, it picks up sound from the front, back, and sides equally, so it is like an omnidirectional microphone. While for high frequency sound, it picks up sound from the front more and sound from the back less and side a little bit lesser, okay? So it acts more like a directional sound, and that's exactly what the natural directionality in MEDAL is replicating, in turn replicating the outer ear functionality. Let's look at the middle ear now. Middle ear has again different emphasis for different frequencies. It allows more of mid-frequency to pass and less of low and high frequency, and that's exactly what the pre-emphasis filter in MEDAL is doing. So in turn it is replicating what happens in outer ear and what happens in middle ear. Now cochlea is a little bit more complex. There are different theories that are working together because it is at the level of cochlea that not only awareness happens but also discrimination of sound happens. So we'll go through all these theories shortly. Now to talk about how does cochlea work, when we hear sound there is movement of hair cells. The hair cell movement leads to stereocilia movement and trains of of action potentials are generated, and when these action potentials go to the nerve and brain, that's when we hear at the level of brain. So at the end, what should happen is that the action potential should be generated in the right way, and that's what we are trying to do with MEDEL. So first is traveling wave theory. So traveling wave theory basically talks about two things. First is about timing and second is about tonotopicity. So what it tells us is when you send high frequency signal, then it is this area which is actually being stimulated, right? So the sound reaches here the fastest. And when you send mid-frequency signal, it is this area which has been stimulated and then it reaches later, and the low frequency sound reaches at the last. So this is telling us different frequency sounds reach at different time, and that's exactly what we are replicating. We are sending different frequency signals and at different time, and metal is the only one who is able to achieve this because we have longest length of electrode arrays, which covers almost all the cochlea possible. Now this is a study where you can see with metal electrode arrays, you can see that the CI are able to stimulate at the same time across all frequency, which is very close to normal hearing, and that's what we want. Now, next thing that traveling wave talks about is tonotopicity. So what does tonotopicity tells us? Tonotopicity tells us when we stimulate different places in the cochlea, you hear different sound frequencies. When you stimulate the basal region, you hear more of high frequency. When you stimulate the middle region, you hear more of mid frequencies. And when you stimulate the apical region, you hear more of low frequencies. So what we are doing here is we are sending electrode array which covers the entire length of the cochlea, and we are stimulating at maximum places, that is 250 different places within the cochlea. So when we send signals in these 250 different places, then the frequency resolution is actually much better than what others are able to provide. So here, this study, you can see pitch is a function of cochlear place, and it is actually replicated by metal cochlear implants pretty well. Now, everybody's cochlea is different. Some cochlea are shorter in length, some cochlea are longer in length. So what we are doing is we are measuring each cochlea and trying to find the most suitable cochlea, the most suitable electrode array for each cochlea, so that the tonotopicity is maintained in each particular patient, and that's why we have 11 different electrode arrays in the portfolio, and that's the maximum which has been provided by any companies. The third feature of cochlea is compression. So what baselab membrane does is it provides higher emphasis or higher gain to low level sound, and it provides compression to the high level sound, and that's exactly the AGC of our cochlear implant processors working on, and that's how they are able to provide amplification to low level sound and compression to the high level sounds. And now we have the most complex phenomenon, which is called phase locking or temporal coding. So temporal coding is actually very important, and the funny thing is this has been clear to us just in the last 10 or 15 years, okay? So what does the temporal coding tell us? If you have a fundamental frequency of 200 Hz, then the auditory nerve fires 200 times. If you have a fundamental frequency of 500 Hz, then the auditory nerve fires 500 times, okay? But what the conventional strategies were doing was, even if the fundamental frequency was 100, 200, 1000, 2000 Hz, they were sending constant stimulation rate. So they were sending 1000 or 1200 pulses per second. So of course, the action potential were being generated at a higher rate, okay? And these were the coding strategies which led to good speech understanding, but did not lead to good music perception and natural sound quality. So with the help of ES users, it became clear to us that temporal coding is very important. So now the fine structure coding, what does it do? It takes over the fundamental frequency. If the fundamental frequency of the sound is 200 Hz, then the stimulation rate is 200 pulses per second. So the alternate fires are stimulated 200 times, right? So it is following the fundamental frequency of the signal. So we are able to code every coding that happens in cochlea as it is, and that's the reason when you ask a patient today, what is the difference between the sound that you heard before and now, they say it's almost nothing. So that's how we're able to reach closest to natural hearing. And look at this study here, you can see that the 100 Hz tones nearly sounds at 150 Hz. So that's how we are saying, we're not saying we have reached the natural hearing, but we have reached closer to natural hearing. We still have a lot of work to do, and we are doing the work, and hopefully very soon we'll be able to reach further closer to natural hearing. So you see, there are three things which are important for closest to natural hearing. You stimulate in the right place, you stimulate in the right way, and stimulate in the right time, and Medal is the only company which is doing all three of this. And recently we have come up with anatomy-based fitting. So here what we are doing is we are looking at where exactly electrodes are placed in the cochlea, and we are sending the same signal or the same frequency to the cochlea, so that the mismatch between frequency that was sent versus the frequency that was perceived was minimal. And after this we have had wonderful responses. People have said that this is the closest to natural hearing that they have been able to hear. And now with all of this, you know, why do we need to hear closest to natural hearing? We need to hear closest to natural hearing because that means there is more natural sound quality, there is best possible speech perception, music perception is good, sound localization is good, and the overall benefit is best, right? So Medal is not a company which focuses just on selling implant. It focuses and it hits hard with the technology, with the education, and we are trying to see that we overcome hearing loss as a barrier to communication and quality of life in a very right way. So that's it. This ends my presentation. Thank you for your attention.
On the recent technological development, so that ultimately is the patient will benefit with a closer to natural hearing. That's such a wonderful presentation. Thank you for enlightening us. Thank you, Shefali, once more. Okay, we'll go to our final or third speaker, Ms. Shabnam Fatima. She's a rehabilitation manager and clinical support. So let's hear from her. Over to you, Shabnam.
I think I would like to focus a little bit of the time that we have in the symposium on the idea of early intervention, and this is a collection of what we learned through outcome research. So when we have to study the idea or the effect of early intervention, we have to kind of make sure that there is a very high level of collaboration between the different professionals that are involved in working with children with hearing loss, starting from the group of people who whose responsibility is to do the identification as early as possible, to the therapist who's responsible to bring up the child to the level of the hearing peers. So everyone's role is really, really important, and I'll just quickly highlight as to what are the what research says on this. So when we talk about how do we select research that is based on early intervention and its effect, it's very important that these three things are mentioned in that research. The first is how good is the access to the auditory environment. The second is how optimal is the auditory environment, and the third is how optimal is a child's language environment so that the child is able to benefit maximum from the cochlear implants or other hearing implants. So any research that targets two or more of these items is considered in this presentation. So as a background, I think what we have to understand is the effect of hearing loss does not end as soon as the child gets the hearing implants or the switch on is done. It's a continuous process wherein I think we see even children who've been using implants for more than 2 or 3 years still trying to struggle to cope up with their hearing peers. So that's where the idea of early intervention is really important because we are promising as professionals to the hearing impaired children and the families that we are going to do whatever is in the best interest of the child. That is, we are going to try to identify their hearing loss as early as 1 month of age. We are going to start the intervention process as early as 3 months of age, and if the child requires implants, we are going to do that as quickly as possible so that the child is by the time the child is 2 years, the child is at a level where his or her hearing peers are performing, right? What are the different, I think the two most really important factors that are related to this outcome. One is the effect of deprivation. We all say that, you know, the deprivation period should not be very high, or it should be as less as possible. The reason behind that is, if a child with hearing loss has to compete with his hearing peers, this child with hearing loss should be having a very good verbal output that is intelligible to any listener. So that means the child should be getting a feedback of what he or she is speaking as early as possible. And that's why it's very important that the deprivation period is very less, because the child gets the auditory feedback as long as possible. And how do we know that once a child gets implant is as the child starts babbling, that is, or vocalizing, that is the first sign that the child is receiving auditory feedback through the implants. And the second thing is also the quality of the language environment. So it's not just enough that the child is wearing implants, going to the therapy session, but it's also very important that we know what exactly the child is having access to in terms of language. How rich is the language environment? So keeping these three things in mind, right? So we start with making sure the monitored learning, that is the therapeutic process after the switch on, is as highest quality possible. We make sure the child has maximum access through the CI system, which practically translates to optimal access to speech sounds through the cochlear implant system. And next also we have to, you know, parents by themselves do not come with all the knowledge that is required to support these children once they are going through the therapeutic process. So we should have programs that are in place that sustains their understanding of what their child is undergoing when the child is learning language, right? So also, I think one of the most important, apart from the language aspect, is how well is the speech getting monitored of, by the child. I'm not talking about the child's speech getting monitored, but the other speech, how well the child is able to monitor and grasp from that. Now that is something that is really important. And also this directly translates to how intelligible the child's speech is. Okay. So in terms of three aspects, I'll start with the surgical correlates. So we, like I said earlier, I think making sure the child is having complete access, and with metal cochlear implants, I think these three factors are really important. First is the depth of insertion is a direct indicator of how intelligible the child's speech is. The angle of insertion, that is the greater angle of insertion, is also a direct correlate to intelligible speech. And the other thing is whether the electrode is within the scala tympani or not. That's also a direct correlate. So why I'm highlighting this factor is, if you want any child with cochlear implant to speak well, I think the person responsible starts from the surgeon. They have to make sure that these three factors are in place, right? And then we have the audiology correlates, and the most basic thing apart from access to all the speech sounds is that how much time is the child wearing the device. That becomes really important, and I think from a minimum of 8 hours it goes up to as high as 12 hours per day. That is ideal for the child to develop intelligible speech. And then, of course, there is in between this wearing time and how well the child is hearing intelligible speech, it's very important for me as a therapist to know how much of an access the child is getting per day. So indirectly, how I do this is, trying to calculate the hearing hour percentage. And also the device usage that is there. Again, those are direct factors that leads to intelligible speech. And of course, we have this wonderful tool called the Little Ears Auditory Questionnaire and the Little Ears Speech Production Questionnaire that acts as a screening tool for you to identify the hearing loss for children who are less than 18 months, but it also acts as a progress monitoring tool for children who are implanted early. These tools has helped us identify in India that the rate of learning of children with cochlear implants is very fast, and it becomes comparable as early as 12 months after implantation if the child is implanted within 1 year. Now that's very important. This is the beautiful graph for us to know how they are competing with their normal hearing peers. The dark line is the normal hearing peers, and you see those dots are all the children with cochlear implants, right? So technology-wise, we have this, most important things, which is, I think, front-end technology-wise, we have to talk about the ANR and TNR that's that's available with our Sonnet 2 processors. That also is a direct correlate for speech intelligibility. The FSP technology is also something that's a direct correlate, and also the ASM technology, apart from the greater angular insertion. Okay, so this is just a quick snapshot of what I just told you. It starts as early as us identifying children who have the development and cognitive potential to receive cochlear implants with severe to profound hearing loss, and going up to optimal access and optimal outcomes. So this doesn't just stop here. I just want to end with us understanding that if we have to implement early intervention process, it's not just something that we speech and hearing professionals and surgeons can take up. It has to be like a general awareness that is created among the public health, which I think Christian just talked about how through his projects and ideas here in Nepal, how that can be initiated. And I think together we all need to kind of bring up the message of early intervention that is very important for children with severe to profound hearing loss. And as professionals, we need to make a promise that we apply processes that ensure that early intervention happens, and a fidelity of these processes is always assessed, and it is tested, and empirical interventions are only used with these children with severe to profound hearing loss. With that, thanks once again for the opportunity, because we care.
Highlighting the early intervention and clinical based research, outcome research work, we got to know about it. And she put a ball in our court, like, as a surgeon, our role is in the initial phase, with deeper insertion, greater angle and full insertion of the electrodes. But I personally say it's only 10% of our job. The remaining 90% is with the audiologist and the speech pathologist. So thank you once again for the wonderful presentation. I hand over to...
Thanks for beautiful presentation, all three speakers. Thank you. Question, please, sir.
I would like to request the chairpersons to kindly receive the token of appreciation from the registration desk outside. Thank you very much.
Good afternoon, ladies and gentlemen. This is me, Pratibha Sarai. I will be the host for the rest of the scientific sessions. I welcome you all on this international conference organized by SHANCON here in Nepal. We now proceed with the mini symposium in Hall A on the audiological management and oral rehabilitation with cochlear implant. I invite the chairperson, Dr. Ravibhushan Swal, and Ms. Stephanie Casey to the stage. Professor Dr. Ravibhushan Swal is a senior consultant ENT surgeon and a consultant professor with over 15 years of clinical experience. He holds an MBBS and IMS in ENT from Bibikoirala Institute of Health Sciences and has completed a fellowship in cochlear implant surgery. Dr. Swal's key area of expertise include ear surgery, particularly cochlear implant procedures, as well as the comprehensive management of hearing and balance disorders. He is deeply committed to advancing surgical outcomes and improving hearing rehabilitation for patients across all groups. Ms. Safari Casey is a senior audiologist at Madan India Private Limited. She has 9 years of experience specializing in implantable hearing solutions, including adult and complex cochlear implant fittings, management of malformed cochlear cases, and autoplan analysis. I welcome you, ma'am. For the first lecture, I'd like to welcome Mr. Siva Ganeshan to the dais. I would also like to request Ms. Safari Casey to introduce the speaker.
Shiva Ganeshan here is a very good friend of mine, and just to explain what he does, he's an audiologist and speech language pathologist. He serves as an academic coordinator and ASLP faculty for the Hearing Healthcare Alliance across South Asia and Africa, and as assistant professor at Morpheus Chennai. So he's been very busy and he has been doing a lot of things. We welcome you, and the stage is all yours.
Thank you, SHANCON, for providing opportunity to present my topic here. So I would like to welcome you all for my mini symposium. The mini symposium will be on cochlear implant. The first lecture will be carried out by me, and second lecture followed by lecture will be carried out by Anuradha. So I would like to discuss today the topic of objective electrophysiological measures in the assessment, fitting and optimization of safe performance. So before moving on to the topic, I would like to introduce myself. Myself Shiva Ganeshan. I'm an assistant professor from MOF, Chennai, India, and also I'm a regional academic coordinator for Hearing Healthcare Alliance. So without further delay, I would like to move on to the topic. So I have classified today's topic into 3. The objective measures which are used in intraoperative, objective measures which are used in fitting, objective measures are used to validate the fitting. In the first category, I would like to talk about intraoperative measures. The intraoperative measures are the very important comprehensive electrophysiological test battery. It's going to say about electrode position and implant position and electrode integrity. So, and also it's going to give them more useful information like correct positioning, again electrode and some electronic integrity. So first let me just introduce the important part of the topic. So I would like to discuss the intraoperative measures. So these 3 are the major important measures which we should carry out in a traditional cochlear implant measures, which are known as the impedance measure, decap measures, and ESRT measures. Getting the information from this telemetry, we are going to monitor the coupling of the implant, integrity of the implant electronics, and also it gives the important information of active electrode array. It's going to say about the electrode impedances, ground path impedances, and voltage field along the cochlea, and also it can help us to measure and detect the short circuits. So intraoperative telemetry gives valuable data. So we should always rely on an impedance field telemetry or an impedance measure whenever the patient comes to the visit. So it's going to be repeatedly, we are going to repeat these measures. It gives a compliance and also it's going to say about all the electrode tissue integrity issues. So impedance values, it can be vary person to person. There is no we have a normative which should be less than 20 kilo ohms, but still there is no normative across the patients. And also it will stabilize after a year of surgery, after a few months of post surgery, it will get stabilized. I'll move on to the second test in the intraoperative measure, which is ECAP, also known as the electrically evoked compound action potential. We already have an idea about compound action potential. The action potentials are produced by nerve fibers. Here the action potential will be produced by electrically evoked. So you can see a negative deflection. This negative deflection is nothing but a good response. And also in the bottom graph you can see an amplitude growth. So what it suggests is when I increase the current level, the amplitude is going to increase. So if you see this pattern, the linear increasing. So it says that whenever I increase the current, there is an increase in amplitude. It suggests there is a good response. So let me put some more characteristics about ECAP. So it is a response to an electrical stimulus, and it is produced by synchronously activated nerve fibers, and also it is recorded by the intracochlear electrode. We don't need a separate electrode to record. And when we are recording with the intracochlear electrode, it has some advantage. There is no muscle artifacts, there is no signal processing by the brain. We don't need the EEG activity, and independent of patient status, and also it gives the information about the peripheral hearing system. So, coming to the interpretation, I have already given an idea about the negative peak, the negative deflection, which is nothing but the presence of response. When there also the increase in the current also should increase the amplitude. So this relationship between the amplitude and the current is going to confirm the responses. So it's a very much useful tool, and it is easy to it takes less time to finish. And also it helps us to measure the dynamic range, and it also helps us to correlate with the upper stimulation level, and it helps us to for the quick fitting approach, which we will be seeing in the fitting category. So next important test, electrically evoked stapedius reflex threshold. So stapedius reflex threshold is a reflex which is elicited by your brainstem nuclei, SOC, superior auditory complex. The same reflex we are going to use it to measure the cochlear implant performance. So here we simulate through the intracochlear electrode. We just take the electrode which has a good impedance, and then we will simulate a biphasic pulse, a burst stimulus, or you can use a speech burst based on the company protocol. And once you have given this pulse, a doctor in intraoperative is going to look into the stapedius muscle. So where you can actively see the stapedius muscle movement. So in intraoperative ESRT, it is more of visualizing the stapedius muscle contraction. So the current levels can be increased in the 15%, and we can increase or decrease the current level based on the response or contraction. So when the contraction is when there is the minimum level where we are getting the contraction is nothing but the ESRT, the reflex threshold. So here you can locate the stapedial tendon. In the next video, you can see how it is going to contract. You can see a jerky movement, which is nothing but a stapedius muscle reacting to the current. Okay, so the intraoperative ESRTs, it's going to give the information about the nerve physiology, but still it is poorly correlated with the C levels. The ESRT which we are recording in the intraoperative cannot be directly correlated with the MCL due to the recording parameters. And when you compare the intraoperative ESRT with the non-sedated other tests like ECAP, EABR, it has a poor correlation in the outcome measures. So next, I have finished the intraoperative one, and next I will move on to the fitting criteria. So during the fitting, we need two important tests again: ART based fitting, ESRT based fitting. So electrically stapedius, we have already a physiology idea, but in post-operative, there is a difference in a recording parameter. So in intraoperative, you have an advantage of looking the stapedius muscle, but once it comes to the surgery, you can't visualize the stapedius muscle. You need a separate system to record the stapedial reflex. So we need a help of a tympanometer, which should be in the reflex decay mode, So we will also have the programming software. We will give a current pulse from the programming software and we will place the probe in the contralateral ear. So whenever I am giving a current, both separate muscles gonna contract. So this contraction can be recorded by measuring the compliance change in the contralateral ear. So main thing, as we are just relying on the tympanometer, we should have a good compliance in the contralateral ear. The B-type tympanogram or any middle ear compliance, like a reduction in the compliance can affect the test. So here the lowest like deflection value in the reflex decay, we will take 0.05 as a reflex measure, where we are just saying the less in the flat reflex as a will above the point is a threshold. So when you are getting the minimum current where you are getting the deflection is gonna known as a ESRT here. So you can see here the traditional setup will have both programming software and also a traditional tympanometer, which is set on the reflex decay mode. So the dilemma in ESRT, intraoperative ESRT cannot be used to correlate with the MCL, whereas the post-operative ESRT is a good correlator with the MCL level. For the pediatric cases, to predict the M levels, it is going to help us more. So, and other challenges in ESRT, it is relying on the impedance. We know that we should have a separate equipment, and also we are relying on the compliance and the middle ear status. So next, after ESRT based split, there are more to the ART or ECAP based split. So it is almost similar to the intraoperative ECAP. We are not going to change anything. It's the same protocol. So once you are saying that we will give a biphasic pulse, followed by you will get a negative N1 and P2. So P1 will be masked by the stimulus. So you will get one negative followed by a positive. So here it is an indication. And in Mastro, the middle software, we have a EC ART based fitting. So once you started fitting the patient, you will have an option to do the auto ART. Once you did the auto ART, so you can directly program the mapping based on the auto ART. So the auto ART is going to give the mapping contour and it's going to help you to put the mapping configuration just within 1 or 2 minutes of time. So this is how it look like in a Mastro. You will have a ART based fitting. Once it is done, you can just directly go to the fitting window. The values will be directly reflected there in the fitting. So I have come to the final thing, fitting validation. This is the important point. So once after doing the intraoperative and fitting, so we need to know that whatever the current level we have given is enough for the patients. So it is nothing but the outcome measures. So we have some 3 important outcome measures too. Firstly, I would like to keep the LLR because it's going to give us information about cortical. And then we have a EABR. Again, the EABR can even use in the intraoperative, but not in every case. When there is a nerve anomaly, when there is a need of, like in a very rare case phenomena, we can keep that too in an intraoperative. And ESRT here we are going to keep it in a different way, which is known as an open field ESRT. So let me introduce LLR. LLR is a non-invasive procedure. It is almost, this is a test which is going to give us an idea about the auditory cortex and brain maturation. So it is a non-invasive method. You will have electrodes on your vertex, and then you will have a negative ground electrode on the lower forehead, and then you can keep the negative electrode on the contralateral ear. So in this setup, we will have a P1 and N1, P2 complex. Here it will be from 50 to 150 millisecond. In this duration, you are going to get the P1, N1 and P2, N2. So this LLR, this response of LLR, the amplitude, latency, morphology of LLR, directly related with the patient age, patient hearing status, and how before they have did the implant duration. It's going to directly affect the characteristics of LLR. So here I can show 2 graphs. In the left you are seeing a graph where there is a auditory maturation. It starts from the newborn to the adult. You can see in the adult you have a very clear P1, N1, P2. It says that there is enough maturation and enough auditory development. In a younger way, the same way it will act in a cochlear implant or hearing loss, hearing impaired patient. Once they have a hearing loss, there is no hearing or there is no stimulation is given to the cortical level. So you can see in the right side, one patient before cochlear implant. The same patient, after 1 year of cochlear implant, CAP is recorded in 3 different speech stimulus. So what it means, before giving a cochlear implant, there was a flat. After 1 year of cochlear implant, it's giving a very good response from the cortical level, that is 50 to 150 milliseconds. So it is indicating there is a good speech processing, speech perception. It's not speech perception, there is a processing in the cortical level. So we can easily say that the patient is getting benefit from the cochlear implant. And then EABR. So EABR is actually a tool mostly used in preoperative, like in the morning, Sir said about transtympanic EABR. And also we can use it in the intraoperative when it comes to vestibular schwannoma to monitor the nerve status or in nerve anomalies. So we can even have the EABR in intraoperative. But postoperatively, we can also use it to check our fitting validation. So we can put it in the last mapping and we can just stimulate and we can still find out the threshold level. So the setup is very same like ESRT. Here we are going to have a programming software in the left and we will have the ABR recording device in the right. So it will be both will be connected and communicated with the trigger cable. The ABR system should know when you are giving that stimulus because ABR is an onset and phase lag response recording protocol. So once you are giving, somebody need to tell ABR the stimulus is given and it should start the recording. So we have a trigger cable in between. This is the important person who is going to make the EABR possible. So we will give a traditional biphasic pulse to check. And the electrode placement is as like a traditional EABR placement. And the difference in the EABR and ABR, you can see the two graphs. The top graph is nothing but the acoustic ABR and a conventional ABR. And the bottom graph is a EABR. So what is the major difference? Nothing big. The morphology is little different. So you are not getting the first peak here because the first peak is completely masked by the stimulus artifact. You have a large electrical artifact, and then you have a good morphology in the acoustic ABR. Here you are missing one first peak, and another thing is latency. So these two are the major difference between conventional and EABR. So here the latency will be 1.5 to 2 milliseconds earlier than because of the near point stimulation. You are giving the stimulation through the intracochlear electrode. So in a conventional, we are just using the insert earphone at the level of ear canal. So by correlating the EABR values with the CAP, it is going to give a great idea about your patient and outcomes of your patient. So this is a recording which we did recently in teaching hospital using a PARC device. So it would be nice if you have a very good double channel audio emitter to reduce the noise. And we have a recorded PARC medical device. So we have got a very good first, third, fifth peak. When there is we did this EABR when there was a doubt about ECAP. This patient didn't have the enough satisfactory ECAP. So once we went to EABR, they have a very good EABR. Then we found there was something in the external processor. So it is also going to help us to measure, outcome measure, also to check the auditory physiology. So to conclude my presentation, I would like to highlight other recent advances in the objective measure. So I said about ESRT, open field ESRT. This is almost like a traditional ESRT, but instead of giving the electrical pulse, I will give a live stimulus through the speaker. So it can be a very good measures for in outcome measure. There are results are going. Now intraoperative, like in the morning they will be discussing about structure preservation. And also in the next tomorrow's structure we will be mentioning about some structure preservation and residual hearing preservation. So we have an intraoperative intracochlear electrocochleography. It's going to give it's going to very fruitful tool to measure the residual hearing, and also it will help us to the structural preserving. And autoplat, again anatomy based fitting. You are going to say angular insertion depth. You're going to say how far the electrode inserted. We can choose the electrode. We can reposition the frequency, reallocate the physical frequency. So and then sir in the morning he mentioned about auditory nerve test system. It's very recent. So even the patient who is not getting enough response from transtympanic EABR, they're getting a response from that. So with this, I would like to conclude. I'm happy to take any question after this. Thank you.
Now for the second lecture, I would like to welcome Dr. Anuradha Sarma on the podium with the topic Personalized Listening Journeys, Tailoring Habilitation for Literacy Outcomes in Diverse Listeners. I would also like to request Dr. Ravi Bhushan Swal sir to introduce the speaker.
Dr. Anuradha Sarma, she did PhD in speech and hearing, and she is a faculty member in the Department of Otolaryngology, Speech and Hearing Unit in PGI Chandigarh. And Dr. Anuradha Sarma has over 20 years of academic and clinical experience at PGI Chandigarh, and her research focuses on cochlear implants, tinnitus, adult neurocommunication disorders, dysphagia, autism, and the role of yoga in communication sciences. She has authored over 38 scientific publications, contributed a book chapter, and co-supervised certified master's dissertations. Dr. Sarma has led and collaborated on several funded projects from ICMR, DST, CCRYN, and NNS. She has received awards including the Best Publication Award at CIGICAL 2022 and serves as a reviewer for the Journal of the Indian Speech and Hearing Association.
Personalized listening journeys, tailoring habilitation for literacy outcomes in diverse listeners.
A small announcement for the poster adjustment. We'll be having that session after we finish the panel discussion. So I want everyone to be present here until we finish our panel discussion.
So let's begin my presentation. I'm going to talk about listening. As we all know, we have been talking about speech, language, hearing development, but we've never spoken about how these children are doing academically, what is their progress, what are the minimum requirements, what are the challenges we faced. So I'm going to show all this in brief and try and touch upon every aspect of it so that everyone takes away something from this presentation. Thank you. So these are the things I'm going to talk about. The first one is the components of literacy. I'm going to talk a little bit about on neural correlates as well, the challenges that are unique to India and the challenges that are affecting literacy, the effective methods, how can we help these children. So let's begin. We all know that hearing is what provides access to language, and language is the door to the literacy. And somewhere or the other we have seen all our cochlear implanted children facing speech and language problems or reading writing problems in their classrooms. We have been talking about integration, but these children have been facing some or the other reading writing skills issues or difficulties in their classrooms. Now first looking at what are the components of literacy. The number one is phonemic awareness. So what is phonemic awareness? Phonemic awareness is completely auditory. That means you listen to the sounds of a language, segment them, blend them, manipulate them, and then form a word. Like what is written here, ka, a, t. That makes us cat. So awareness of the phonemes occurring at the auditory level is what we call as the phonemic awareness. Next comes your phonics. Now what is phonics? Phonics is correspondence between the written language and the sounds of the language. So that means now is the time when your written language will be corresponding with the sounds that you hear. So this is very important when you are starting to read and write. Next is your vocabulary. Vocabulary is, we all know, building up vocabulary helps in oral communication, better communication, but it also is helping in reading comprehension. So the vocabulary also helping in communication, but indirectly is also helping in reading comprehension. The fluency. The fluency means the ease, the accuracy, the fluency with which we are reading or understanding. So at that time, we are not facing difficulty in decoding which sounds are there, what should we say. Instead, we are easily reading the words of the language. Lastly, we have the comprehension, the reading comprehension. So here, we infer what is written. So अगर कुछ paragraph है, तो सीधा पढ़ के हमें समझ में आए कि this is what is written. We don't have to understand कि उसमें क्या letters हैं, क्या sounds हैं, nothing. We just infer the meaning and we relate it to what we had understood or heard in the past. So these are all the components that we have in literacy. Next, I'm going to talk a little bit about the pre-literacy and literacy development. So there are various aspects of this. The number one is birth to 2 years. As you can see here, I have highlighted a few aspects. So here you have rhyme awareness that is occurring. The children start pretending that they are reading, but they are actually just turning the pages. They are scribbling some letters or drawings. So that is what is occurring from birth to 2 years. Then 2 to 5 years, somewhere they start segmenting words, they start segmenting sentences. They start understanding small stories if you read to them. They start getting sight vocabulary of the words. So such things start erupting by the age of 2 to 5 years. Then 5 to 7 years, they become the real readers. They become readers, they have sight vocabulary, they understand whether the words are of the similar consonants or similar together, whether they are different from each other. They segment the phrases, sentences. So this starts erupting by the age they are 5 to 7 years. They have spellings errors, they form spellings, they have lowercase, uppercase alphabets coming in picture. And lastly, by the 9 years, they have usually sent messages, text messages, everything is occurring by the age of the 9 years. So this was a little bit about how the literacy is developing. Next, what is the relationship? So we are talking about listening and literacy. What exactly is the relationship? The relationship is, this is a study which talks about emergent literacy. So emergent literacy is combining of two components, written language awareness and phonological awareness. And how does it come? They say, the more oral language you develop, the more reading readiness you have. The more reading readiness you have, the more written readiness you will have. So in turn, जैसे जैसे आपकी भाषा बढ़ेगी, वैसे वैसे आपकी रीडिंग बढ़ेगी और जैसे जैसे रीडिंग बढ़ेगी वैसे वैसे राइटिंग बढ़ेगी. ये तीनों इंटरलिंक्ड है, जो नेक्स्ट डायग्राम में भी बहुत खूबसूरती से दिखा रहा है कि you have auditory processing, then you have metacognitive skills developing. Metacognitive skills lead to phonological awareness and phonological development. उससे reading spelling बढ़ रहा है, and when that is happening in turn, they are interrelated. So language is also increasing that. A little bit about neural correlates. So there, I just wanted to highlight here that there are two pathways. One is dorsal and one is ventral. So एक जो है हमारा visual aspect है, where you see the sight vocabulary, you have vision to spelling conversions, spelling and hearing conversions, and one is auditory based, that is your dorsal pathway. So these two pathways are involved for reading, and in writing there is more of motor areas, visual integrations, and for typewriting it is more of the cerebellum and the superior parietal lobe involved. So this was an interesting study they did in China, where they found, they did a study where they had Chinese discrimination, words, letters discrimination and figure discrimination. So what they found was कि literate और illiterate brain दोनों same थे. They did not find any difference. But only difference they found was the three areas: the angular gyrus, the supramaginal gyrus, and the third one was inferior parietal lobe. So why these three areas? They said these three areas were different because they are responsible for attention, memory and language processing. So एक illiterate और literate दोनों पहचान सकते हैं कि ये शब्द है, पर उसका मतलब क्या है, वो क्या represent करता है, that is where the illiterate and literate brain difference show differences for fMRI. So there these three areas were only different. So there is a difference even on fMRI if you are literate and illiterate. So what are the challenges and factors in literacy development? So सबसे पहला है phonological awareness difficulties. You can see such a big list of hierarchy, starting from manipulation, blending, segmenting, phoneme awareness, rhyme awareness. Child has to know all this to have the phonological awareness. So this is very important. If anybody wants to work on phonological awareness, you have to go about these steps. And the studies show that language skills and phonological awareness is very much affected in cochlear implanting. Like this study, they said that children have phonological awareness and language skills difficulty, which was shown on listening, semantics and syntactic skills. There was a one standard deviation almost difference between the two groups. This also clearly indicated another study by Sophie et al. And they said that like in print knowledge, both the groups, that means जब written language थी, both the groups were at par, but on the phonological awareness, the cochlear implant group fell one standard deviation. This was also a very interesting study. They used self-test, which is a standardized test for language. So they did the light gray ones you can see is the ones part of language. The white ones are the written language, and the dark black one is the reading comprehension. So what this was that the middle line is the normal score. So the children with cochlear implant, they fell 1.6 standard deviation below the normal here on both the oral language tasks and 0.69 on the other components. Even on reading, writing, passage comprehension, they were far below. Similarly, on the reading, passage comprehension, they fell short. So what we can see, the two areas, one was phonological awareness, then was language developmental delays. So the third thing is age of implantation. We all know, younger the child, the better the literacy outcomes. So this was a very interesting study. अब तक जब भी मेरे पास कोई unilateral hearing loss का patient आता था, we never told them to go in for a cochlear implantation. Now as the trend is changing, जब मैंने ये study पढ़ी, I realized it said कि अगर आपके पास तीन ग्रुप हैं, एक normal hearing, एक single sided deafness और एक single sided deafness के साथ cochlear implant. So if you can see, normal hearing और single sided deafness cochlear implant were at par, मगर जो single sided deafness was not implanted, उनकी narrative skills 8 से नीचे रही, उनकी auditory memory 8 से नीचे रही. So they showed very specific areas where there was difficulty. So narrative skills, auditory memories, they were also affected in single-sided deafness. Then what are a few challenges which are unique to India? I don't know whether they are actually unique to Nepal as well. So what we see is multilingual classrooms. So most of the schools in India, almost 61.6, this is Union Ministry of Education presented in Parliament this data. So 61.6% schools offer multilingual languages and number of students that are learning is 74.7. So you can see how many languages, more than 3 languages, 74.7 children are. And this is another study. This talks about, so this talks about group A was French children, only monolingual French. Group B was they were using French, Portuguese, 3-4 languages. So what they saw was on phoneme identification, minimal pairs and phonemic balance kindergarten test, both the groups were similar. But when they did deeper testing, the bilingual children were, the 50% is the normal score, the grey line in the center, that's the normal children. But the monolingual children were above that level, but bilingual were far below. So they did not even match anywhere on vocabulary understanding, vocabulary production, sentence comprehension. All these areas were affected on those children. So this is the data of percentage disability Sensex 2011 India. So you can see 35% of children almost have hearing difficulty and almost 25% are having speech difficulty. I'm not very clearly able to see. And the number of special schools that are in India are so variedly distributed. And amazing thing is that 0.98% of these are only going to primary level and only 1.08 are going to the schools in this. So how many of the children are left uneducated and illiterate? We have to be amazed about that data. That is why Government of India, I don't know whether Nepal has this. Does Nepal have open schooling? National, any kind of open schooling education program in Nepal? No? So India has this very beautiful education board that they've started. It's called as National Institute of Open Schooling, where the children, if they fail in one paper or 2 papers, they can give only that paper and pass. Or if अगर मैं deaf हूँ और मैं सारे पेपर एक साथ नहीं पढ़ सकती, तो एक-एक करके सब्जेक्ट इसमें दे सकते हैं. Then you can go back and keep passing as your capabilities. Because उन सब बच्चों को hearing and language difficulty होती है, so this has come very handy for many of my children. And third thing is school teachers are not well prepared. So this is a survey from Kerala in 2024, and what they found was even the teachers didn't know. Like you can see the data here, the hearing loss existed, the CAPD, all this. How many percentage of teachers didn't know that there can be difficulties because of this? Then, do you know that hearing can affect academic performance? Almost 79% of didn't know. Actually, it can cause difficulty in academics. So, then they did not know about any assistive listening device. You can see 75% of them didn't know whether assistive listening devices can help them. So there is a lot of need, even in India, for making the teachers aware of these things. Again, whether there can be different techniques or different instructions that can be given to these children, the teachers are not well aware of these areas. So what can we do? Now moving on to, we have talked about difficulties, challenges, what can we do? Early implantation, the first thing we know is that it impacts, if the child is implanted before the age of 2, 30 to 40% improvement in listening and language, and after that there is a significant decline in language milestones which will lead to literacy delay. So audition, this I think everybody knows. So how do we start with the child singing in a relaxed tone, intonations use karo, long vowels, respond to them, praise them. This is a beautiful slide. I show this a number of times. I think middle people must be very well aware of this slide. So if they are using the implant 100% of the time, they have normal language by 3, 60% time, so they will have delayed spoken language. If 20% of the waking hours they are listening, they will have severe language impairment. So now you can see how well it will impact, the audition will impact their speech and language, and in turn their literacy outcomes. So what do we do? I found this slide very, very helpful because we as speech language pathologists only make rehabilitation goals. हम में से कोई भी और literacy goals नहीं बनाता. So what I tell my students is, when you are starting with rehabilitation, start making literacy goals. Make phonological awareness goals. वो table जो मैंने अभी दिखाया था बड़ा सा, we start them from a very word goal. Start with syllable deletion, syllable segmentation. Those gains, those tasks, you make short-term goal on those. Monitor their speech scores with literacy scores, both of them. So this is what as rehabilitationists we have to do. Parents क्या कर सकते हैं? Start reading at home. वो भी घर पर phonological games खेल सकते हैं. I'll show a few games further. Teachers क्या कर सकते हैं? Include them in classroom. Use assistive listening devices. Make them a part of classroom. So this is the difference in India and some rural and urban schools. And this is the number of children that are getting educated. Maximum children are getting educated from the urban background, and maximum children are actually residing in rural background. So what are the steps we can do? Number 1, curricular modification. That means हम पहले उनका content ही modify करें. Content modify इस तरह से करें कि जो suitable है उनके लिए, start with that. Then tools for assessment. That means we have to have resources, slides, smart TV, so many things which you can use to start resources to support them. Then assessment tools means use tools that are very specific to their needs. Not every child will have. Like this, I found a very beautiful booklet available freely online, developed by Human Resource Department, Government of India. And I didn't know it existed, but when I read about this presentation, it talks about everything that a teacher can do to help the child in classroom. So this is a full booklet that talks about all disabilities. The teacher has to understand कि कुछ content सब बच्चे समझेंगे, कुछ और content कुछ बच्चे समझेंगे, some content बहुत कम बच्चे समझेंगे. That way she has to plan her classes accordingly. So this is a child implanted at a young age, and now she's been integrated into. She was in normal classroom, and how she's.
Hindi worksheet to write the answer.
To write the answer with. And I'll tell you what we did today with the worksheet and with the clock.
IT Hindi worksheet to write the answer.
To write the answer with.
So what we can do in classrooms, background noise reduce करिए, use drapes, try कि बच्चा soft furnishing पे हो, doors को बंद रखिए, ensure that बच्चा जहाँ teacher है उसके पास हो, उसका implant जो है teacher की तरफ हो. Then what teacher can do, repeat, उसका नाम लेके बुलाइए before you start the talk, repeat करिए बार बार, उससे make sure करिए कि he has understood what you are talking, clearly बोलिए, ज़्यादा visual aids use कीजिए, चिल्लाइए नहीं और धीरे बोलिए. Book reading, like Albert Einstein said, if you want to be intelligent, read books. If you want to be more intelligent, read more books. So if you have one book read to your child, जिसके भी बच्चे young हैं, even if they are clinically normal children, please read books to them. You will have 2 lakh 90,000 more words in their vocabulary. And if you read 5 books to them, it will have 1.4 million words more. So the books are very important. These are some of the books that you can use. There are touch and feel books, emotional books, various kind of books. So this is ALDs that we show them in classroom, like audio stream adapter for music, samba for bone conduction, then wireless accessories for TV. So this is a girl talking about how she uses Roger in her classroom. वो कितने हिंदी में बोल रही है कि मैं आराम से बैठूंगी, टीचर के पास रॉजर होगा, मुझे सब समझ में आएगा, मेरे सब कान में जाएगा. So listen to me.
ये पता है आपको मनुष्य का ये क्या होता है? ये क्या है? What is this?
रोजर.
क्या है ये?
रोजर.
रोजर. क्या करते हैं रोजर से?
अगर स्कूल के लिए जाएंगे, मैम की बात से रखेंगे और क्या करेंगे? पीछे बैठ के आऊँ और मैम को लिखिए उठ और ही आवाज निकल रहा है.
कैसी आवाज आएगी? साफ अच्छी आवाज आती, क्लियर सुनता है आपको? अच्छा, मैम जो भी बोलती है आपको बिल्कुल साफ सुनता है? ऐसा लगता है जैसे आपके कान में बोल रही मैम? दूर है मैम बैठी हुई, क्या लगता है आपको? आपको यहाँ सुनता है प्रोसेसर में? ओके, साफ सुनता है आपको? क्लियर सुन?
So how beautifully she explains the benefit she's getting from that. So these are few activities for all our speech language pathologists, especially students, with what they can interpret, what they can do. So number one, like this is the hierarchy that I've shown. I'm not going to read the whole detail, but the activity ideas what I can tell you is, one is your syllable awareness, like this is apple, so identify the syllables that are there, like B, the syllables that are there, so you can, even parents can start this at home. Then there is rhyming activities like hat, cat, nap, map, so such kind of rhyming activities you can do with the child at home. Number of syllables identification, like cat is 1, flower is 2, burger is 3, elephant is 3, how many syllables are there in that word. Then there is joining of 2 syllables. So there is star, fish, there is skateboard, so on and so forth. So many of these ideas. Then there is individual phonemes in that word, MAP, map, PLANE, how many are there, segmenting them, these you can use. And the blends. Finally the blends, the dragon, the dress, the drum and all that. So you can start these activities, do these at home, and this will help you further in phonological awareness. Finally, how to help the parents, you can have a lot of visual aids, use simple language with them, use audiovisual materials, you can have a lot of training programs for them, like, tell them about role playing, build a network, like we have gossip in PGI, what we call is group of cochlear implant parents of PGI, we have their annual meetings, where they talk, where they speak to each other, where they help each other. So if you have worked on ELDs, so the child will go from here to the next.
Very good. Yeah.
Go, 4, 2, 1. Aha, la, la.
So you can go from the concluding that listening is a lifelong journey. Literacy is a lifelong journey, and listening plus language are the gateway. You have to have automatic listening. Literacy does not come automatically after implantation. You have to have it structured, and children can become confident readers if we work on them with a team. Foundation is the ears or listening. The literacy is the goal, and team is the pathway. Concluding, early intervention, intensive therapy, ALDs, inclusive education, emotional support, high motivation. Thank you so much.
Yes, there are some situations where the objective measure which we are using is not enough. So those situations we have to go for the radiological evaluation just to know the cochlea status. Like meningitis or any ossification conditions or tip fold over, but we don't need to worry. In your company there is no tip fold over, but still ossification or the long deprivation period. So those conditions, if you are not getting the enough ECAP or ESRT measures, it is good to go for the radiological measure. So with CT scan, X-ray, going to give some more information about cochlear status.
And I just would like to congratulate both of you because both your talks was wonderful. So what I want to highlight here is what is the difference between a good audiologist and habilitationist versus somebody who is just an audiologist and a habilitationist. Okay. So in Shiva's talk, you talked about validation of maps. It is very easy to do mapping. You just set some levels and you let the child go. But figuring out if the child is hearing right, if the child is hearing the low level sound as low level, high level sound as high level, mid level sound as mid level is very important, and the validation tools are there. If you are an audiologist, you will just do a random mapping, but if you are a good audiologist, then you will validate your map using subjective as well as objective measures. And to talk about therapists, it's very easy to just get a child and do some audition, some language, some speech therapy. But thinking about this child as a holistic approach, thinking about this child as somebody who doesn't just need to listen and talk, but needs to attend school tomorrow, needs to go to probably higher education or some workplace and do the best there. Unless and until we start thinking that, unless and until we start working on entire approach, everything together, it is not possible that our children will have the best outcome at all. So it is, if the surgeon does the surgery perfect, if the implant system is doing the work perfect, the audiologist needs to provide a good access to sound, and the habilitationist needs to provide a good access to everything else, so that this child performs the best no matter in what scenario possible.
Now, I'd like to request our respected chairpersons to provide certificates to our speakers. Next research talk. For this, I'd like to invite the chairperson, Mr. Anil Kumar Adhikari, to conduct the sessions. Mr. Anil Adhikari has over 9 years of experience in audiology and currently serves as assistant professor at the Institute of Medicine, TUTH. His areas of interest include diagnostic audiology, vestibular rehabilitation, and cochlear implants. I'd also like to request Mr. Anil Kumar Adhikari to introduce the speaker.
Mr. Raja Suman Kumar, RC certified audiologist, speech language pathologist, head of audiology and rehabilitation at Sarodaya Hospital and Research Center for Gujarat, India. Raja Suman Kumar holds a master degree in audiology from All India Institute of Speech and Hearing, Malaysia.
Fine. So I think this is audible. So Raja Suman Kumar holds a bachelor's degree from Morph Institute of Speech and Hearing, Chennai. He has an extensive experience in audiology and rehabilitative audiology, having assisted in over 400 cochlear implant surgeries. He specializes in cochlear implant assessment and rehabilitation and has published research in speech perception, neonatal hearing screening, and quality of life in children with cochlear implant. So I'd like to request Mr. Raja Suman Kumar to start here.
Thank you, SHANCON, for inviting me and giving me the opportunity to talk here. Without wasting time, I am going to start my presentation. So today I am going to talk about the speech perception in complex acoustic environments, the challenges for individuals with hearing impairment. So speech perception as such, before going that, I'll give a small introduction about my team. This is my team. We are a group of ENT surgeons, audiologists and auditory rehabilitationists, and vertigo rehabilitation therapists also. Right. So speech perception, as we simply know, it is what we heard and how we interpret and how we understand. That is what the speech perception is, to say it in a simple words. And it has 4 subsections. So speech perception follows 4 patterns. First is the peripheral hearing, where we receive the stimuli and amplify and transmit the stimuli and transform the stimuli into an electrical stimuli. Then the subcortical auditory system transports the acoustic processing into frequencies, durations and intensity, where localization also happens at this part. The auditory cortex mainly make the auditory stimuli into a scene, and at last the speech networks makes it as a understandable input. So the next, what and how does brain perceive the stimuli? There are two things. First, the brain categorizes the stimuli into linguistic units, and then it segments and identifies as a meaningful or a non-meaningful stimuli. So this is an example of a small representation where a child is listening from his teacher, and there is an external noise also, and the sound is going to the ear, and it is being transformed into speech signals. Then the brain understands the signal. So complex acoustic environments I am categorizing into two things. First, environmental with multiple competing talkers. Now we are in a hall. If somebody is talking at the behind or on my right or left, so that is also a multi-talker environment where there is a complex acoustic environment is created. Next is the reverberation. There is a distinct difference between echo and reverberation. Echo is a repetitive event where there is an interstimulus time interval will be there, whereas reverberation, the interstimulus time interval will be very shorter. And there are some non-stationary noises such as traffic noise or vehicle noise and all those things. And relevance to our real life, complex acoustic environments can be classified into restaurants, classrooms, or even in our homes also. Next, speech perception in noise. Even after having all these complex environments, how we are perceiving the speech clearly, that is up to two things. One, there is a goal-directed attention. Now I am talking to you, some of you are attending towards me, there is a goal-directed attention that is being taken care of from the dorsal parietal network. Attention also can be driven by stimulus rather than the cognitive process. Second is a selective attention. Now I am continuously talking to you. Suddenly some loud noise, maybe an impulse noise coming, and all of us will be looking towards that side what is happening. That is a selective attention which is being taken care of by the ventral frontal parietal network regions. So goal-directed attention, as I told you, the frontal parietal networks also responsible for your working memory tasks, and the ventral frontoparietal complex are responsible for attending towards unexpected event. So these two things mainly works in the brain to make sure all the other noises are suppressed and our signal is being amplified and understood. Then there are two types of masking or maskers that can happen in a day-to-day life. One is an energetic masking where a loud noise or I am talking to you at maybe 50 or 60 dB sound through the loudspeaker, it may be up to 80 dB. If I am giving a 80 dB noise or a 90 dB noise, that can easily suppress my speech. That is an energetic masking. Whereas informational masking is slightly different. The signal and the masker may be similar or some kind of same languages. For example, I am talking to you in English. If somebody is talking to you in English, you will not be able to differentiate where exactly you have to give your focus. So there the informational masking happens. So this is a small representation of how the informational masking happens. So if you could see, there are different color indications over here, written as Kannada, English, Tamil, Telugu, Nepali and target. So the babble means there are two speakers talking in a different languages, and that has been recorded and use it as a masker. So in this kind of studies, so the individual will be given a targets in terms of monosyllabic words or sentence or keywords. At the same time, they will be given babbles also, speech babbles also through loudspeakers. So if the individual's attention, goal-directed attention is very good, they will be able to focus on the target, they can easily eliminate the masker. Whereas if there is a hearing loss individual, we are testing a hearing impaired individual, they will not be able to focus on the target, they will be confusing the target as well as the maskers. So this is a graphical representation of a long-term average speech spectrum where I have used all these language babbles in a study. So I'll quickly move on to some more studies. So in 2000, Mr. Baroness and Wickstrom have assessed 1,895 individuals. They have segregated them into 6 categories of their based on their high frequency thresholds and their age also. So these are the categories. And when they did the speech recognition score in noise, so across all the age groups, whenever there is a high frequency hearing loss, even though the low frequency is absolutely normal, whenever there is a high frequency hearing loss, which is 2 kilohertz, 4 kilohertz, and 8 kilohertz, their speech recognition and noise drastically reduced. Here the age is not playing a major factor. Even an individual who is 20 to 29 years old, who is having a high frequency sloping hearing loss, they have difficulty in speech recognition and noise. So here the major prediction is poor high frequency thresholds. The next study, which is done in 1989, which is one of my favorite studies, where they have used individuals with and without hearing loss, and they have used a complex masker, which is a multi-talker babble, right? So they have done the study in quiet environment as well as in a noisy environment. Here, if you could see the first dotted line, this is a normal hearing individual. He is able to perform the task even at a higher SNR. His scores are reaching up to 100 up to even in a 32 dB SNR. Whereas in a hearing loss individual, even in a quiet situation, they will not be able to reach 100% scores. And in the dotted, you can see when the noise is increasing than the signal, they are having more difficulty and they are not able to cross even a 60 dB, 60% of their SRS scores. So they concluded that even a small amount of hearing loss in the high frequencies can reduce the speech recognition and noise thresholds drastically. So in this study, they have tested whether the ability of elderly people to understand speech in a competing noise signals. They have used 4 different noises. One is a speech noise, another one is a cocktail noise, another one is a traffic noise, and the last one is a continuous speech. They tried to make it as a realistic environment, and they did the study. They have categorized the groups into 4. First group is an young normal hearing individual. Second group, young hearing impaired individuals. Third group, older adults with normal hearing. And fourth group, older adults with hearing impairment. So these are their Piotron averages, and you can see even in younger adults and in the older adults, the hearing thresholds, they have matched it and they did the study. So in the results, they have concluded that the speech noise and cocktail noise has a steeply sloping effect after plus 5 dB SNR, whereas the traffic noise and the continued speech made to be a most difficult masker. So we can easily say from this study, when there is a continued speech, when there are 4 or 5 people are talking and there is a hearing impaired individual in that particular group, and he is trying to listen to a particular individual signal, they will not be able to do it, because continuous speech gives the most or maximum amount of masking in the situation. Similarly, traffic noise also gives the same amount of masking here. The next study, they have studied the effects of sensorineural hearing loss and aging in the subcortical neural representation. They have did a FFR and analyzed the F0 and the format 1 of normal individuals and hearing loss individuals. So there are 10 normal individuals and 9 hearing impaired individuals participated in the study. These are the results. So the first panel, the A panel is the frequency following response. This is the stimuli. And if you could see the second panel, so can you all appreciate there is a white line in this panels? So these are formants. The darker line is the F0, whereas the other lines are the formants F1, F2 and F3. So in normal hearing individuals, the formants are following, the frequency following responses are following the original stimuli. Whereas in the hearing impaired individuals, you can see the F1 and F2 are diminishing over a period of time. So we all know F1, F2, F3 are most important for speech intelligibility, speech perception based on these formants. So even if a small SNHL can cause diminished F1, F2, and their frequency following responses would be affected and their speech perception would be impaired drastically. This is the reason when we are seeing patients with minimal hearing loss also complaining of difficulty in speech, in noise or in a multi-talker environments. So this study highlighted that neural phase locking for both envelope F1 and F2 degraded in individuals with mild to severe hearing loss, whereas F0 magnitude increases similar with intensity in both the groups. So when we increase the intensity of the stimuli, the F0 magnitude is increasing, but the F1 and F2 is not properly formed in the FFR responses. So intelligibility is less, suggesting a greater degradation even in a mild to moderate hearing loss. So to summarize, so the effects of sensorineural hearing loss on speech understanding. Sensorineural hearing loss primarily affects the inner ear and the auditory nerve over a period of time. Because of the degraded input, the cortex and subcortical structures also not going to respond properly. And audibility and frequency resolution over a period of time, it will reduce. And we can see temporal resolution abilities also. Temporal resolution is nothing but the timing cues. Those are also impaired in SNHL. And in very few patients we can see loudness recruitment. So these are some of the factors which creates a lot of cognitive load. So when a sensorineural hearing loss individual is there, because of all these factors, they need to give more attention, more cognitive, more attention towards the stimuli, where they will lose it or get it. So these kind of individuals, how can we help? So there are hearing aids and cochlear implants and all those things. Those talks are followed in tomorrow's talk, I guess. So as it is a research talk, I will not be able to take any questions. If you have any questions, I am here. You can ask me later. Thank you.
Now I'd like to request respected chairperson to hand over the certificate to Mr. Rajasuman. I would also like to request the chairperson, Mr. Anil Kumar Adhikari, to again be seated as the chairperson and the moderator for the panel discussion. We now move to the panel discussion on surgical, audiological and rehabilitative synergy in cochlear implant care. I invite our moderator, Mr. Anil Kumar Adhikari, along with our esteemed panelists to the stage. I'd like to invite Professor Dr. Pabina Rayamasi, Mr. Sureswar Lal Kern, Professor Ranjit Rajasuran, Professor Sanjay Munjal sir, Mr. Kabiraj Khanal sir.
Now it's time to start the panel discussion. The topic is very interesting. It's one of my favorite topics. And when I'm new to this, so I'm going to learn a lot of things from this panel today. The topic is like surgical, audiological and rehabilitative synergy in cochlear implant care. So basically what we're talking today in this topic is like how the collaboration between the ENT surgeons, the audiologists and the speech language pathologists is important while managing the patient hearing loss with respect to the cochlear implant. So before I start the session, I would like to introduce myself. I'm Anil Kumar Adhikari. I'm working at Maharajanagar Medical Campus Institute of Medicines. I would like to introduce my panel for today, panelists for today. So we have all together 5 panelists today. So starting from the first, we have Mr. Sureswar Lal Kern sir, the first audiologist and speech language pathologist of Nepal. He is also the chief of audiology and speech language pathology unit at TU Teaching Hospital, but he is retired now. He has 40 years of experience in the field of audiology and speech language pathology. He has also received a Lifetime Achievement Award, and he is also known as the father of speech and hearing in Nepal. So I like to welcome sir. Then we have Mr. Kabiraj Khanal sir. He is also the pioneer in the field of audiology and speech pathology. Currently, he is the technical director of hearing and speech and unit chief of speech and language pathology department at TU Teaching Hospital, Kathmandu. He has almost more than 30 years of experience, and he was the past president and the founder secretary of Speech and Hearing Association of Nepal. He is currently the General Secretary of Cochlear Implant Nepal Group, and he has also won Best Employee Award at QTS 2016. Among us we have Professor Sanjay Kumar Johnson. So he is professor and in charge of speech and hearing unit PGI MER Chandigarh, and it's almost an experience of 30 years in the field of audiology, speech pathology. His expertise are like auditory electrophysiology, cochlear implant, tinnitus, auditory neuropathy, and voice. He has published almost 86 research papers and has got 75 presentations in national and international conferences. He is a life member of ISA and CG Cochlear Implant and Cochlear India, India Group of Cochlear Implant Group of India. He has also won a Young Scientist Award at 9th Asia Pacific Symposium on Cochlear Implant in 2013. We have Professor Dr. Pabina Rayamaji. She is an MS surgeon and she has done a fellowship in implant audiology from North Chennai. She is currently the head of department at TU Teaching Hospital. She has more than 19 years of experience in the field, and her area of interest is middle ear surgeries and cochlear implantation. Today, Professor Ranjit Rajeswaran is the Managing Director and the Principal of MORPH Institute, Chennai, and also is the Chief Audiologist at MORPH. He has got 29 years of experience and is specialized in the field of hearing implant, and he is also advisory members of Rehabilitation Council of India and the Vice President of CG. He has established hearing restoration center in SAARC countries as well as Africa. He has guided more than 63 theses and grants. He is invited speakers at more than 30 international conferences, and he was the first person as an audio from API. Now we'll be starting the discussion. Okay, so since the topic is already speaking about the synergy among the professionals, so basically 3 professionals working with the hearing loss. So today, whatever the discussions we are going to do, it will be like how and why the coordination between these 3 professionals is important to have better outcome in the cochlear implant patients. Okay, so I'll just start with the questions. What is the youngest age at which a cochlear implant can be safely performed? So these questions will be for Dr. Pabina Rayamaji.
The 2 points to note in your question is the youngest age to be implanted, but there's a catch to it, can be safely implanted. So let's take into account these 2, okay? Going by the standard guidelines, like suppose we follow an FDA guideline and the US guidelines, 2022 onwards, what they say is 9 months is the youngest age, or the lower limit where the child can be admitted and implanted safely, right? But there are a growing number of literatures which support the child can be cochlear implanted safely, okay? Below 9 months as well. But we have to follow a scientific policy, like say going by guidelines and manufacturing guidelines. FDA 9 months, okay. Going by AOHNS is what they have stated is infant between 6 to 12 months of age can be implanted as far as practicable. That's the word they've used. So let's summarize it. Your question was youngest age as well as when they can be safely undergo cochlear implant. By a standardized protocol with regulatory bodies and manufacturing guidelines, the international norm is 9 months, is according to FDA as well as AOHNS. But our cliche here is when can they be safely implanted? So growing number of literatures, they have stated that they can be safely implanted before 9 months as well. So 6 to 9 months. But people have operated, the youngest reported in literatures have reported children being implanted at 3 to 4 months also. But the catch point is, if you are implanting 3 to 4 months, depends on the patient, the surgeon's capacity, as well as the anesthetic backup that the institution has, and the country as well as the institutional guidelines. Okay. So when do we do it? Like 3 to 4 months. So mainly when the child's need, like suppose say the patient has a history of meningitis and there's a likely chance of ossificans. So the age can be 3 to 4 months. So literature-wise, if we say can be safely implanted, is up to 6 months. So in the nutshell, at the end, what do I say? Majority of the manufacturing guidelines and majority of the guidelines like FDA, international guidelines, what they follow, 9 months. But majority of the countries and our institutional and many institutions, they say 9 to 12 months, right? Till 6 months also, they can be safely cochlear implanted. But as of now, by a standard care, implanting below 6 months of age still needs to be taken guarded. So that's it's around, from my point of view, 6 to 9 months, 9 months to 12. Thank you.
That's a very interesting question, Anil, but you forgot to mention one thing. What is the youngest age at which a cochlear implant can be safely performed? For a child or by the surgeon? Youngest age of the surgeon or the child? Right. So what she said is absolutely right. The most important point here is whether the child is safe and healthy enough to undergo anesthesia, the loss of blood. These are the most important component when you choose the age. If the team is expertise enough to manage surgeries at a very young age, they have a support system, we can do it even, as she said, around 3 to 4 months for the problem. Otherwise, it's basically with respect to the skill of the surgeon, the cochlear size is the same, it doesn't matter. It's only the same age.
So, I think it's very small, I can't see from here. Okay. So next question is, what is the recommended minimum and maximum time gap between the sequential implantation? So this will be to Professor Ranjit.
Yeah, the minimum time is, I would say, 1 day. That's a minimum time. So you do it immediately. That's a minimum time. The maximum time, as per the literature, I think beyond 10, we have not seen any significant difference. 5 to 10, you see some differences with respect to lateralization, but they still have difficulty localizing information. But if you do it less than 2 years of age, the localization scores are improving. So the advantage of having binaural effect, see, there is something called bilateral and binaural. Binaural is synergizing the information from both ears. It's binaural. Bilateral is processing sounds from each ear independently, and binaural is collecting information on both sides and processing synergistically. This is binaural. And this is where the squelch effect, the ability to identify speech and noise, is a binaural effect, not a bilateral effect. So, as early as you do, you will have a binaural effect. If you go later, you will only have a bilateral effect. And we have seen some children who have been implanted beyond the age of, with the duration of 10 years and above, rejecting the second device. They don't use the second device at all, because the plasticity is much more strong. I mean they lose plasticity, and the dependency on the first implanted side on the auditory processing is much more than the second one. So I would ideally say precisely as early as possible. The best is within 2 years, at least within 5 years. Beyond 5 years, the outcomes are quite variable. You don't have the binaural effect beyond that.
Thank you, sir. We have a question and answer session at the last, so if there is any questions, just note it down.
Excuse me. Why you told remove that 1 day? Why not 1 hour? Same sitting.
If you do it 1 hour, it is not sequential, it's simultaneous.
Yeah. So, which approach is better, sequential or simultaneous implantation, and why? So this will be to Professor Gunja also.
See, I think this I presented in the morning also. I presented some data also. Simultaneously, of course, simultaneous is the best option, because within 1 day, with the same anesthesia, so the procedure can be done, and the rehab, as far as switch on is concerned, it could be done in the tooth. On the same day, healing also takes simultaneously, so the child doesn't have to go through the same trauma again, which happens in sequential implantation. Okay. So the better approach, of course, definitely is simultaneous, and even the outcomes have been measured where the comparison has been made between simultaneous and sequential, and it has been found that the simultaneous implantation leads to better outcomes, faster growth of speech and language abilities. So simultaneous is definitely better than sequential.
Yeah, I totally agree with sir, because I am working as a rehabilitationist. So again, the client has to face 2 times training, same training, and again and again. Because of sequentially we do, again we have to close the 1 year, we have to work for another year. So the simultaneous.
Well, actually, I agree with you. Most part simultaneous, but sequential is also important on certain conditions where you have a patient with atypical etiology, where you have 1 year, severe to profound loss, but completely infected in the middle year. Okay, and first priority is to clear the infection before you do an implant. So in those conditions, where bilateral severe to profound loss, but one side is completely infected with the middle year. So in this case, don't go for simultaneous, go for sequential. Do the better side first, and then plan the second side later when the infection settles down. So only in these conditions, you prefer the sequential thing to do it. And simultaneous is a very interesting question because I don't know how many of you watch all the science fiction movies. So nowadays, you can do surgeries with both hands at the same time. That's also simultaneous. So simultaneous for the surgeon or simultaneous for the patient is
the best surgical and orthological solutions for single-sided deafness and why? So this will be two questions.
It's a very, very interesting question. So there are 2. Single-sided deafness is usually identified by the age of 7 years in general, because when the child is born with congenital single-sided deafness, where 1 ear is absolute normal hearing, another ear is profound loss. And it's very difficult unless you do a universal newborn screening and identify. It is very difficult to identify because the child will respond even for the soft sound because 1 ear is normal. So the average age at which we pick up single-sided deafness is around 7 and above. Usually it is 7, and that's what we've seen. Now the treatment option is very simple. Now the question is whether the child wants to hear both ears or the child wants to hear from both sides. Right? If you want to hear from both sides, you don't need to do an implant. But if you want to make both the ear to hear function, then you need to do it. Right? Because for a single-sided deafness, there will be 2 options. Either you put an implant on the deaf side and make that ear functional, or you put a bone conduction device on the affected side and transmit the sounds from the affected side to the better side. Now the biggest problem is, advantage is you don't have to do any surgical procedure. But the drawback is you will still not have the effect of understanding speech and noise. The speech, it is still unilateral, or I would say monaural, right? You will not have the binaural cues. Now the best is always to go for a cochlear implant. I can always say at least 1 ear is completely safe. In case if the other side also hearing goes drops down, at least 1 ear you have a permanent hearing with the implant. Now you use a bone conduction device. The bone conduction device is as good as the bone conduction threshold of the better side. If the bone conduction threshold of the better side goes down, then this starts. Now the second thing is, and why I'm answered because of the binaural effect. One is that you go for an implant, and one is go is fluctuating. Here you will have and what is the best surgical and audiological? Yeah, I think implants. Cochlear implants are the best single-sided.
Best option is opposite option.
Always you make the ear function. You always make one organ function. If you put an implant. If you don't put an implant, you are not using the organ. You are bypassing the sound from the affected side to the better side. It's still a monaural, it's not a binaural. Not a bilateral. It's just monaural.
So, we have the next question. What is the key surgical criteria for cochlear implantations in ANST patients? So, this will be to Professor Ranjit and then Professor Abhinay.
Okay. So, this is very interesting. The question is key surgical criteria. for cochlear implant. The moment we talk about surgical criteria, we think of two things: side, which side we go to implant. Because ANSD is usually bilateral. You will also give unilateral ANSD. In unilateral ANSD, we are not worried about cochlear implants because one side is absolutely normal. We usually go for intervention when you have ANSD bilateral. But if the patient cannot afford for bilateral implants, then they can afford only for one implant. But the question is which side you will implant. Right. Now, what are the diagnostic indications for ANSD? Variable hearing thresholds, OAE is present, ABR is absent, acoustic reflexes absent, speech perception is very poor. Right? Now, in most of the cases, you will see the same results on both sides. So it's very difficult to differentiate between the ears based on the regular audiological investigations. So you need to go for some extra investigations, that is additional investigations, like you can use a cortical potential. Now the reason why cortical potentials you can use is, ABR is a test of neural synchrony. ABR is not a test of nerve conduction. Only if there is a synchronous conduction in the nerve, you can measure ABR. For example, patients with chronic neuropathy can hear sounds, but ABR is absent. So does it mean the nerve is not conducting? No, the nerve is conducting, but the nerve is not conducting synchronously. Okay, it's a time block response. That is to measure the auditory potentials at the level of brain stem. You need a very high synchrony firing of the neurons. But if you want to measure the potentials at the cortical level, you don't need that much of synchrony. Or rather, there is so much of neurons available to listen. For example, you do a cortical potentials in a patient with ANSD. Right here, you are getting a good cortical potential. Left here, you are not getting a cortical potential. That means you implant the right side. Right. On the other hand, if you are getting no cortical potentials are absent on both sides, or you are getting cortical potentials present on both sides. Now, then what you do is you do an electric ABR, trans-tympanic ABR. You take the patient to the OR, elevate the tympanic membrane, put a needle on the promontory, give electrical stimulus, and measure the ABR. Look at the latency and morphology and the amplitude of the ABR. Whichever side has better amplitude, better latency, shorter latency, and good morphology, choose that side for an implant. Okay. Next important point that you need to consider in surgical criteria is what type of electrode are you going to use in ANSD. Right. So ANSD, see, you have different length of electrodes available. So I would always prefer to use an electrode which is customizable for the cochlear size. So you cannot use an electrode whichever we like. So you measure the cochlear duct length and choose that electrode, and always perform atraumatic surgery, which is called the hearing and structure preservation surgery, HSP, hearing and structure preservation, which means when you put an electrode inside, it should not touch any other structures inside the cochlea except the lateral wall of the scala tympani. Right. Now what will happen? The hair cell is functioning well. That's why you're getting good OEEs. Why would you damage the hair cell? Because tomorrow, if you want to do an autofurling is a very fantastic treatment for ANSD. So you don't need a cochlear implant. You just put an autofurling treatment. Without a cochlear implant, they hear like normal. But it's not done in many places. Only in very few places are done. In India, yes, ICMR has not given permission to do it. But tomorrow, if autofurling is acceptable to do it in India or in Nepal, they should have a structure present, right? So you have to preserve the structure. So you have to do a hearing and structure preservation atraumatic. So what is the audiological role in this surgery is we do a test called the intracochlear electrocochleography, which means as the surgeon inserts the electrode inside the cochlea, I can measure the, looks like this auditory system has ANSD. It's not proper. Not unilateral, decently. Okay, so as the electrode goes inside, what we do is we put a small transducer to give acoustic sound. The acoustic sound will make the the basal membrane move, and the hair cells will respond for this movement. And the hair cell will produce cochlear microphonics. When you put a cochlear implant electrode inside, you can measure the cochlear microphonics with the same electrode. By looking at the amplitude of the cochlear microphonics, you can guide the surgeon if the electrode insertion is damaging any structure or not damaging the structure. If it is touching the basal membrane, the cochlear microphones will go down. If it is not touching the basal membrane, the cochlear microphones will stay good. So by looking at those values, we can even guide the surgeon how to insert the electrode without causing any trauma into the cochlea. So if you ask, the key surgical aspects of AMSD is selecting the site using these audiological procedures and selecting the right electrode and doing atraumatic insertion and monitoring the atraumatic insertion using intracochlear decompression. Now, after putting a cochlear implant inside, then you will have to measure ECAM, you will have to measure ESRD, and you will have to measure EABR. Because prior to cochlear implant, ABR is absent. Now with implant, ABR is present. We need to check that. Prior to implant, acoustic reflexes are absent. After you put an implant, check with acoustic reflex. I'm sorry, the electrical stability reflexes are present. If you can restore stability reflex and ABR and an ECAM, that means he will be a good candidate. The performance will be good with the AMSD.
Ranjit, I want to share one recent experience which we had. We had a case of ANSD and we did the transthympanic ABR and it was absent. So then we discussed with Dr. Mohan and he suggested for ANTS. Okay. So ANTS is again assisted by the middle. Okay. So where you place the electrode in the cochlea. Okay. So we did that and we got such a beautiful waveform. Okay. So it's looking at only EABR, we would not have gone for cochlear implantation. But when we did the ANTS, okay, and we got a good ABR waveform. So that's how the technology can add. So if EABR is absent, still there can be some hope. Okay, can try ANTS and if the response is present. So we in that same setting, because for doing ANTS you have to do the cochleostomy and then put the electrode inside. So already half procedure is already done. Okay, we think we have to make a bed and then insert the electrode. So we did that and that was quite an experience for us.
He's right, but to give you a little more clarity, ANTS and both are EABR. Whether you use ANTS or you use a transtympanic electrode, both are EABR. But the electrode is on the round window edge and ANTS electrode is inside the cochlea. That's the difference. When you go inside the cochlea, you're stimulating more neurons, right? But the thing is, I would always advise to use ANTS only during the cochlear implant. If the patient is willing to go for an implant, you know why? Otherwise, you open the round window, you are damaging the structure, you cause an infection just for measurements, right? But on the other hand, if the patient is willing to go for a cochlear implant, why ANTS put the regular implant itself also you can measure? So it depends on how you make your choices depending on the infrastructure.
Ma'am, like to add something to that? So round window versus cochleostomy, which is best and in which case you should each be chosen?
Thank you, Anil. So let me revise the question. Round window versus cochleostomy, which is best and in which case should each be chosen? Let's go by the result first, okay? Round window is a normal anatomical pathway. So let's go by the literature, the outcome. Literatures have mentioned that the outcomes are not much of a difference in relation to the speech development later in life. But pre-operatively, when we have to choose, okay, as a surgical point of view, so which is best? It's a tailored approach, okay? Rather than saying which is best, let me decide when to choose round window and when to choose cochleostomy. So, literatures have mentioned, there are many meta-analyses, many randomized controlled trials which state that when you have a normal anatomy in a patient with adults or children, when we are planning for cochlear implant and you are planning for a hearing preservation surgery and less of a tissue trauma, the literature supports the route is round window. But the preferred route, when there is an anomalous cochlea, when there is an ossified cochlea, and when I am doing a revision surgery, when the round window access may not be so easily visible, the preferred route is cochleostomy. But let me make one statement, okay? a very nicely performed cochleostomy approach has a better outcome than a poorly executed round window. That's my view. So at the end, how do I end it? It's a tailored approach based on the child's anatomy of the cochlea, the hearing need of the hearing preservation surgery, and whether I'm doing the surgery in a routine, normal anatomy case. Okay, then I would rather go for round window approach. If I'm doing a cochleostomy approach, it's the anomalous, it's the ossified, and the revision cases that I would rather prefer. And even the literatures prefer that. So that's it. Thank you.
Well, I completely agree with Dr. Babina, but to give a little more clarity, the difference between round window and cochleostomy is the position of the electrode inside the cochlea. When you do a cochleostomy, there is a high chance of electrode translocation. That is, it is moving from scala vistibuli to scala media. Electrode can do. The high chance of electrode kink. Okay, there is a very high chance that if the cochlea is a little rotated, if the surgeon is not well experienced, it can go into the vestibule also. Right? But if you are doing a round window, you are sure you will only go to the scala tympani. Right? But as she rightly mentioned, the round window procedure is not just opening the round window and just, there are two types of round window. Round window and extended round window. Round window is better. When you put an electrode inside through a round window, the insertion technique is important. You need to insert it very slowly. Right? Which means if you have an electrode which 12 electrodes, the length of 28 millimeters, the average time taken should be considered for a good insertion is 2 to 2.5 minutes. 2 to 2.5 minutes of insertion should be. That is why to control the speed and the force of insertion, the medal has come out with a technology called the auto arm. Okay, it's an automatic motorized electrode insertion. So the difference between cochleostomy and round window is number one, the position of the electrode inside the cochlea. And as she rightly said, if it is oscillate cochlea, there is no question of round window. Anomalies, of course, you can only go with cochleostomy, no doubt about it. But think about these two differences.
Next question is surgical approach considerations and electroacoustic stimulations and related audiological factors. Question to Dr. Sanjay.
Thanks, Anil. Surgical approach considerations in electroacoustic stimulations. Electroacoustic stimulation means the candidacy would be. I'll start with the candidacy. Okay. So we'll consider it only when there is a moderate degree of hearing loss in low frequencies and severe degree of hearing loss in high frequency. So there also the first line of option would be, in my view, would be hearing aid. Of course, and now we have technology where you can have RIC hearing aids, or if there's no hearing in high frequencies, we can have frequency transposition. Then there are various techniques available now where the high frequencies can be transposed on the low frequencies, and there are certain, of course, I'll say 30 to 40% of patients who get benefit with this. The rest of them, they do not get benefit with this approach. So those will be the candidates which can be considered for electroacoustic stimulation. Personally, we do not have any experience. We have not carried out any ES at our institute, but this is what the literature says, that yes, if the hearing aids are not giving benefit, and this is, and morning I also discussed in the recent trends of CI candidates in that year. So this is a group where low frequencies can be stimulated through the hearing aid, and high frequencies can be stimulated through cochlear partition. So that's what.
So to be very specific to your question, surgical approach consideration in electroacoustic related audiological factors. So the surgical approach in electroacoustic stimulation is objective measures guided surgical incision. Because what happens at the apex of the cochlea, hair cells are functioning fine. That is why low frequency you have got good hearing. High frequencies are affected because base of the cochlea is affected. Right. So when you put an electrode inside, you should not damage the apical area where the hair cells are functioning very well. You should not damage the functional hearing there. So how does the surgeon know how deep he has to insert? So which means if you look at the length of cochlea from 0 millimeter to 28 millimeter, and if you look at the audiogram is around profound loss at 2 kilohertz and 20 decibels in 1 kilohertz. How does the surgeon know how deep he has to go to stop at 2 kilohertz? He may not know. So this is where you need a radiological guided prediction. That's called Autoplan. Autoplan will help you. It's a software where you can feed the radiological image of the cochlea of that person and feed the audiogram into it. It will camouflage the frequencies over the cochlea. It will tell you at what position this particular frequency is there. There is at what length of the or what insertion depth it is. That plus your intracochlear ecology measures. So when you put an electrode inside, when the hair cells are not functioning, you will not get any ecology. But when the hair cells are functioning well, then you can measure it. So you know at this point the hair cells are functioning, the hearing is good. So you can guide the surgeon either to stop at that point or to do a deeper insertion without causing trauma. So the surgical, there is objective measures, guided surgery is the most important in electrophysiology.
One question. Suppose somebody has got high frequency loss, better notification. For the time being, you do the EAS, and later he develops hearing loss with the low frequency. Now you have inserted the electrode up to the certain length only, not at the lower frequency. What will happen that time?
So that's what we do nowadays. We don't do a shallow incision. We do a complete incision. We do the complete cochlear coverage and we try to preserve the hearing and we reserve those electrodes. Later if the threshold falls down, you can activate those electrodes. So awesome.
So next question is, what policies could be implemented to increase cochlear implant surgery availability and awareness, particularly in context of Nepal? So this will be to Dr. Gardner sir as well as Dr. Pavina.
See, first to increase the number of CI candidates, then only you can do number of more surgery. How to increase? First thing is awareness, public awareness. What is possible things are there. Cochlear implant is there, that can be repeated. That is one thing. Second thing, early identification. How you do early identification? By doing neonatal hearing screening. Third thing is educating the medical doctor, pediatricians, gynecologists, those who do part of this for the surgery. Child going first to the pediatrician. So we should educate the pediatrician, medical doctors and gynecologists also for the neonatal screening, this to be specialized, and referral, early referral. So what we are seeing in Nepal, it improved now, but when they go to pediatrician, my child is not speaking at the age of 3 years, no problem, give this tonic, he'll improve, he'll speak after a few months. Somebody speaks late, like that they do. They used to, now they have improved. Because of Dr. Pavina and Dr. Ravindra, our CI surgeon have done so many continuing medical education CME for the pediatrician and other doctors. So education is more important. Now, fourth factor is money, financial things, which we know that Nepal is a poor country and most of people are poor. They cannot afford it. So, government should start funding all the children up to the age of 1 year onwards, and all the adults also. At present we are getting funds from government partially, and that is criteria up to 6 years of age. And government is funding only, I think, it is 6,50,000. Whether it costs 30 lakhs or 20 lakhs or 50 lakhs, doesn't matter. Government has got fixed support. That also put fixed number of the cases, not unlimited cases. So in that case, it cannot happen. Government policy should liberalize certain subsidy. If they cannot do full subsidy, certain subsidy for those who need, all the needy child or adults. Only supporting for the surgery, partial support for surgery is not enough. They should put some money for the rehabilitation. Unless until orphans are more better, people are not motivated for the surgery. They agitate, oh, they are going to cut here in the brain. But when they see that child has improved a lot of the CI surgery, so I should also, how they improve? If you select early age and good candidacy and good rehabilitation program. So good rehabilitation program, they should regularly attend the rehabilitation. And if they are poor, they don't go. So if government supports for at least for 1 year of rehabilitation expenses, that will again increase. One more factor is, when before going to surgery, they ask the old parents after difficulty. The child has gone under CI surgery, what challenges you face, what are difficulty you are facing. If they are getting negative feedback from the parents, then that hampers. So how they get positive? Like, oh, very expensive. See, it's not one-time expenses. After 5 years, I have to, I replace the processor. Again, I have to spend the investment of 8 lakhs rupees. So then they scare. They scare, oh, again and again expenses. So government should make a policy, a standard policy, to replace the processor at least after 6 to 7 years in this country. Whereas in the US or European countries, there are standard rules. After 5 years, they replace the processor. If you do all such things, the number of CI cases will increase. That's my opinion.
Well, the question is on how to increase the CI surgery, right? So I think it's a multifaceted approach. One person, one institution, and government only, they cannot. So when we say increase the CI availability, let me break into the problem. So there's a need to increase the CI surgery, right? So what are the problems? So what I feel personally is there are four aspects where we need to increase. First, the cost. Where is the problem? Why we are not increasing the numbers of the CI surgery? The main aspect is the cost. Are we tailoring to the marginalized, to a very poor children or the families? No. So that's the one is the cost, but that's the risk. How are we going to mitigate it? The mitigation is, yes, the government policy should increase and have some other schemes to increase from 6.5 lakhs, right? That is the cost. Another is the increase in the resources and the infrastructure, which I feel is necessary. What is our CI plan? It's based majority in the Kathmandu center with the major hospitals like TUT, IOM, with NAMS and Patna Hospital, and few centers are available. Do we need policies to improve CI centers apart from Kathmandu Valley? Yes, we need, right? So increase in the number of the trained audiologists, habilitationists and surgeons as well. Now, do we increase CI only, or do we have a protocol-based and monitored CI surgery? Yes, my personal point is it should be monitored. Don't increase the CI surgery only. Let's have a monitoring, let's have a feedback, improve in the outcome. Okay, that's what I feel. So that is resource and infrastructure based. And as Sir has said, increase in the screening as well. Okay. Now next is the government policy. What is the role from the government? ours is, compared to other countries, the neighboring countries, even in India, our country is ad hoc amount of 6.5 lakh, that's it. No, we need to advocate for increasing the amount, maybe to marginalized people, maybe to some children who, family who need, okay? And the government should have accredited and monitored based protocols of CI surgery, way to do, when to follow up the patients, and when, like suppose say if the person is from rural areas in Nepal, if I do a surgery, increase the surgery, after 2 years they might not be using it. So do we have policies to track them? That should also be there. And lastly, what I feel is the last is the awareness. How to improve awareness is advocacy again. Advocacy from all the stakeholders. So who are the stakeholders? All the people in the hall, okay? CI surgeons, the audiologists, the habilitationists. Apart from these, the Ministry of Health, I think the provisional health ministers, even the NGOs, INGOs, all should come into one picture, okay? Then only increase in the amount of CI surgery. But still I say, not increase the amount of CI surgery only, increase in the amount of patient benefiting from it, the children benefiting from it. So let's say at the end, it's a multifaceted approach, not a single person or a single institution approach. It's a multifaceted approach. And lastly, I would say, involve the parents as well as the peers around also. Unless they are involved, we are only from one side. They are the one at the gaining side. So let them also be involved in the team. So it's a multifaceted approach from all the stakeholders in cost-wise, institution-wise, infrastructure-wise, as well as the government policies. So that's my personal view.
I agree with whatever both of them said, but the most important point is money here. Without money, nothing works. But the question is, how do you get money? That's the most important thing, right? What you need to do is you need to have a pilot study on cost-benefit analysis, right? If I invest 10,000 rupees on this child, the government is investing 10,000 rupees on this child. When he becomes an adult, what is the benefit that I'm going to get out of it? So if I invest 10,000 rupees, I'm going to reap 1 lakh rupees. 1 is to 10 is the benefit. So the policy makers will only understand this language. So the cost of the cochlear implant is, let us say, 500,000 rupees, which means how much money that we going to spend per day. If you spend 50 rupees or 10 rupees or 20 rupees per day for this child for 5 years, you will reach 500,000 rupees, right? So all that what you need is you need to spend 50 rupees per day. Okay, if you invest 50 rupees per day on this child, by the age of 18 years, the child will produce the outcome that you're going to get out of the child will be 10 times more, because he will be a productive citizen, he will be contributing, he will be a taxpayer, he will be independent. Otherwise, he's a burden to the country, he's a liability to the country, where the country has to spend money on him. So this is the language we need to do. So you need to study and show the data to the government and policy makers to keep us. Parallelly, you need to create infrastructure, right? Infrastructure at all levels. And the simple reason is, any system that we build, okay, has to have, it should be focused on the most important thing, availability. That is, if I sit in some place in Nepal, Chitwan, okay, if I sit in Chitwan, okay, I can be traveling for a surgery to Kathmandu. First, it should be available in Nepal, then it should be accessible to me. Most of the people don't come for surgery because they have to travel a long distance. The third is affordability. And the last most important is sustainability. I can give an implant today, give a processor. After 1 year, the processor comes off, battery has to be changed, the patient does not have the money, again he becomes a non-user. Sustainability. So focus on these factors: availability, accessibility, affordability, sustainability, and cost-benefit analysis. If you do it, very simple, the government of Nepal doesn't have to fund everything. The WHO, there are a lot of NGOs, there's a lot of other international, UN, all those people can fund if you have the system in place. Those people don't fund because there is no system in place to see the cost benefit. If you establish that, funding will automatically come. There is no dearth for money in this world. There are only dearth for ideas and lack of system.
And one more point just came to mind. if going by the literatures, we can also follow modules that are being followed by developing countries to build it. Like for example, we can take into account India, Pakistan and Malaysia even. So how they went about, that can also be taken into account in,
No, it doesn't
or is
work.
it different in Nepal
Don't-
only?
Don't take any country's model because you have your own uniqueness which is different from that. You have to develop your own model which fits into your health system and your structure, statue of your flow. That's very important.
Right. It's just a pushing to the, suppose say the policy, we have to follow up on, but we can give examples like certain countries.
When a policy is based on statistics, you need to give your data. If I am the Secretary of Health, I want the data. If I'm investing 10 rupees, what am I going to get? And there is a system to get that 10 rupees. If that is laid out, I'm willing to put the money into it. If that system is not there for my system, I will not compromise.
Yeah, but for that we need first to do a pilot study.
That's what I'm saying.
That's
Data, your
it.
own
Then we
original
follow.
data.
Once we have advocacy program with Health Minister, Health Secretary, and all IIT people, CSMs, I suggested cost-benefit analysis. Cost-benefit analysis. How I suggested I am different way. Government is giving certain amount of allowances to all the handicapped children for lifelong. Suppose a hearing impaired child, he doesn't go for the CI salary, he is staying at a handicap, hearing handicap. If he survives for 80 years or 70 years, how will be the hearing nowadays? So if he survives for 75 years, 80 years, how much you are paying him per month? What is the amount? And if you are putting the amount now, the early age, he will become the productive citizen as well as less expensive. But they still government is that.
So next question is like why might behavioral and percentage scores be better while objective standards are poor post-apply? This is something which I've been seeing in few cases. So what could be the possible reason for that? So, no, sir.
Okay. But no, that's best. You will start.
In my opinion, behavioral and perceptual scores may be better even though the objective measures are poor. So now, it depends upon parameters of the test we are using. And state of awareness of the child, that interpretation by the audiologist, how well he has interpreted the text. And time of test, which we have post-surgery and pre-surgery. Post-surgery, when you are measuring, these are the factors which affect the behavioral improvement of behavioral scores. Secondly, the age of the child, that what CSL were done, and how well the application has been done, and at the same time etiology. So these factors also make difference. Now even though everything is done correctly, all the parameters were correct, and testing, everything, the chances of improvement is much more post time, because due to electrical stimulation, development in more neural connection happens. So as the number of neural connection increases, we have improvement of behavioral scores will improve. That's my opinion.
Well, I think it's a very nice question because objective measures are limited, but perceptual measures are unlimited. It's a difference, right? language will develop for a very long time. But EABR, when you do it on the day one, or an ESRT or an ECAP, you measure it on the day one, or you measure it after 5 years, it's going to be the same. There's no difference. So objective measures are limited, and it measures only limited component of it. Only measures the action potential of the neuron, or the ability of the stiprial muscle to, stiprial reflex. Beyond that, it doesn't measure anything, right? But languages and speech is something which is exponential. So it's a question of what test are we using to compare? For example, you have a patient with absent ECAP, an absent ECAP. You thought there is no ECAP, but the child is able to hear, the child is able to speak. Well, that is possible. But have you compared a child who has got good ECAP, child with poor ECAP, speech perception and noise? When you do the speech perception and noise, or a certain timing test, temporal test, they will do much better. So it's a question of what test we use. You will have a poor response in the temporal cues. Okay, but a patient with good ECAP, good EABR, good reflexes will do very good in temporal test, timing cues. So it depends on what test you are correlating. Because ABR is a test of neurals, it is only testing a limited element. So there is always a correlation. The objective measures correlate very well with your subjective outcome. Depends on what it is.
Okay, so the next question is the minimum assessment tool set required to evaluate pre and post cognitive outcomes. This will be to Gardner sir as well as Vyas.
Hello. I say minimum means unaided, we have to compare unaided threshold and aided threshold. Second thing, we have to perform a speech perception test in white and in white. These two things, in my opinion, is minimum should be to evaluate. So we have to compare the pre-implant and post-implant both. You can do a lot, but only two things I'm telling, minimum.
Yeah, see, you need a minimum audiological tool to do the sensitivity of hearing first. The minimum audiological tool used to measure the perception of sound, pre and post. Minimum speech language evaluation tool to assess the audition, comprehension, expression, cognitive. So this test are all well standardized. These are the minimum tools that is required to do it. And of course, I think there are a lot of other, it's called the MOA minimum outcome measurements. There's a lot of consensus are published. One of the consensus that I would recommend all of you is you go to the hearing consensus on MOA minimum outcome measures. Hearing, HEARRING. You go to this website, HEARRING. They're given beautiful consensus on all those things.
Yeah, just I want to add more. The minimum means at least we need audiogram or short wave testing. After that only you can find out the aided threshold. Aided threshold that is the pre-implant aided threshold by the hearing unit. And even way ABR is the minimum. And even the child has some language, you can use some language test also. And some maybe only they have articulation problems, that depends on the degree of hearing loss. And second is post-implant, post-GI outcome. For that, of course, we need aided threshold, that is the after cochlear implant, which is very much important. So you can see the outcome, you can see the child. Then peculiar auditory questionnaire are very common, like CAP score, read perception, and sir, especially getting his care. Those are the minimum, I think, test we need.
Now another question is again interesting. When should speech therapy or auditory verbal therapy start after cochlear implant surgery? So this will be to Kavira's answer.
Yes, auditive verbal therapy, of course, we have to start after cochlear implant, but we have like a pre-implant therapy, which is also important. If child has some residual hearing, we can fit the hearing aid, like from the hello acoustical measurements. The low frequency is better, high frequency is better. That body who are in that condition, even can give hearing aid, and we start verbal therapy. There is not only auditive verbal therapy, visual tool also there, but auditive verbal therapy, I think we have to start after switch off. We should not be. Actually, what I found, even parents, even child also after getting some stimulation, child wants or vocalize more. If we delay, we will not teach the meaning of sound. What is sound? Different pitch wise, loudness wise, vocalization. So we should start as early as possible after the switch off from the switch off.
Next one is how frequently should auditory verbal therapist be conducted post cochlear implantation for optimal outcomes? This is to Kavira's
Actually, earlier I used to give everyday therapy, which was started in my first case I got. But our practice is now 3 times in a week for 1 year, and after that 2 times in a week, another 1 year, then once a week for the articulation, intonation, visual perception, like that. But that depends on the how we teach the parents, how we train the parents. If child is very early age, see, we cannot give like a full formal auditive verbal therapy, because that informal way we can teach child, we teach the parents daily activity, informal incidental teaching, and other activity also. So this is the experience. If a young child, no need to worry that much. At least 6 months to 1 year is crucial therapy time. Then they develop. We have to save the language, articulation, intonation, and MLU. We have just to save.
I want to say a little bit. See, the number of times of therapy per week depends upon the age of the child and the parents, dedication of the parents. Therapists know that parents' roles should be very clear. If you carry out the therapy every day or so, if parents are lazy, family members are not involved in the program, it will not be effective at all. So, it varies from child to child, family to family. If parents are all motivated, good family members have to be involved in that. Then no use of the everyday therapy. So, first of all, we have to motivate the parent, we have to explain them the importance of their dedication, their involvement. If they are involved, then number of therapy times should be less, the cases should be less. We should allow them to do more work. Then duration. It is not feasible for all the parents as surgery done only in the Kathmandu or two places. One outside the Kathmandu and one nearby 3 centers. 2 in Kathmandu or 2 outside. So it is not feasible for parents to stay in Kathmandu for longer period of 3 years. Like Mr. Karal said, 1 year, 3 twice a week, 1 year, twice a week, then once a week. It is not feasible. Practically it's not feasible. It's not feasible for all the parents to maintain such a longer period. So I say initially 3 times a week, depending on the progress child is making, we should gradually cut down the therapy session, and within the year we should complete all the 2 sessions. The next year about 1 session will be more energy, high quality progress. But it is not fixed for each and every time. Same.
So we have just 2 questions left now.
Yeah, this is the last question.
No, we have one last question for everyone. This is the second last.
Why I'll finish it off because this has been discussed earlier also endlessly, but I'll give you 2 important points. The criteria. The first criteria is number 1 is the speech perception score. That's more important. If the speech perception score is less than 50%, either with the hearing aid or hearing aid and FM device, then he needs a doctor. Right? That's the most important criteria. But whether to go for right side, left side, what you plan, how to do it, I've explained it for you. So the basic criteria, speech perception score, less than 50% with hearing aid or even with hearing aid and FM, if it is less than 50%.
How important is non-verbal communication in children with cochlear implant? This will be to Kamala sir.
Yeah, actually earlier we used to say child is using sign language, gesture language, facial expression. It may hamper the auditive perception, but I don't agree. That's why the non-verbal communication is very much important because that is actually it will help for us to more strengthen the language. If child is using gestures, we can put the gesture, we can put verbal repetition. If child is smiling or nodding the head, oh, you can hear telling, I don't want, no. So it is easy for us to teach language. I think that is quite helpful.
To this question and also to the previous question, the non-verbal communication is more important for people those who can hear well and speak well, because most of them people speak nonsense. It's better to communicate non-verbally. Yeah. So the non-verbal communication is part of our communication process, so I agree with you. So the last question, how can surgical or audiological rehabilitation teams synergize for optimal outcome is the team should be aligned in terms of latest updates, in terms of updating the skill. The team should be aligned in decision making as a group decision based on ethics and good clinical practice. If these things are in place, that's the best synergy for the best outcome.
There has to be a respect among all 3 professionals for better outcomes.
See, this is basically theme of the conference, based on theme of the conference, which I have already talked more than half an hour this morning. Multidisciplinary approach. So team here, all surgeon, physiologist and speech therapist. Not only these things, other disciplines have to be involved. There has to be synergy between all the professionals. The importance of why it should be there. I have already discussed it.
In our practice, generally what we do, we select the case. Before selecting the case, just after doing the auditing evaluation, then we call out the different disciplines like speech language pathologist, audiologist, psychologist, and we sit together and we decide for the operation, cochlear implant operation. After that, in between also, our ENT surgeons, they ask, okay, what is the progress of the sleep? We meet and discuss. I think this way we have to go together. Then it will be good for the child language development.
Yes, the same here. There's a good communication, respect for each other, and a shared goal. What is the goal? Ultimately, it's the patient who's going to benefit. That's the shared goal. So that's it.
Thank you, ma'am. So we are already at the end of the panel discussion. So the questions what was put today has summarized everything. And we know now why it is important, why it is needed to synergize. So I'd like to thank everyone once again.
His primary area of interest lies in vertigo and electrophysiology. As a published researcher, reviewer, and national guest, faculty Dr. Sharma is a dedicated professional contributing significantly to the advancement of audiology and vestibular sciences. I also request all the presenters to please go on the left side of the hall. I'll take this moment to introduce another panel of judges, Mr. Radhasugan Muthukumar. Radhasugan holds a degree in audiology from All India Institute of Speech and Hearing, Mysore, and a bachelor from our Institute of Speech and Hearing, Chennai. He has extensive experience in diagnostic and rehabilitative audiology, having assisted in over 400 cochlear implant surgeries. He specializes in cochlear implant assessment and rehabilitation and has published research on speech perception, neonatal hearing and quality of life in children with cochlear implants. Judges, invite you to begin the evaluation. The posters are displayed outside the hall on the left side of the hall. In the banquet dinner. You are all welcome to the banquet dinner.
Chairman, what an honor to get a certificate signed to me.
Hello, how are you? If you select this participants randomly, they come to view the complaint. What is the duration of animations? What is the duration of speed?
My target was up to 200 samples, which can benefit from the results also. You can see all the languages cases because obviously for us there might be more cases which we have not got for the rehabilitation, so we have to go deeper and also the small to the affecting ones. Oh, so patient came with a difficulty in swallow and also wasting was there.
What was the primary? Whether it came for a swallow or
Also, for the both, yeah, and but the patient is more focused on swallow because so both of them are out of 50 or 5.
Since when they are complaining for this swallowing issue?
So swallow issue was for the one case it was after the maybe from because we was far away from.
Since how many years was having this issue?
Also not years, it was months.
Suddenly it
Suddenly it had occurred. So he had a change in status, yeah.
Because why I'm asking is, when this patient is showing, you should get a scan now. He might lead into multiple things.
So he did have a leprosy relapse as well. So he had a relapse, one of the patients had the problem, and so he had to restart his leprosy medication along with the swallowing changes.
So there are two things. Either the medication what we are using, is it that effect because if we do a long term, or because we get these patients suddenly when you have these voice issues, you are fine. Then when you do a scan, yes, I had some couple of patients. Ended up when I was 26 years old.
Post leprosy?
No.
Oh, just different cases. Yeah.
Just she has a what I But then we asked her, what are your do you find issues? I have certain issues in school. And then we just, because why this case is in mind.
Yeah.
That's one thing which we should consider that suddenly when they come, especially some scans we need to do. Hospital offices.
10 days they were in hospital with us, then we did the strategies and they went home, and after the 2 months they had come again home.
Nothing in terms of fee after meal? Yeah, they might, but yeah, they want to semi-liquid and all sorts of, yeah, so they do it. They get adapted to it.